So we are continue with Dr. Anderson's series in a much more interactive way. So we are combining clinical cases with the morphology features of all the cardiac diseases. This series has been amazing. So it's every Friday. We hope all of you can join us. We are going to have, restarting in February the 8th, Dr. Silverman with his amazing correlation of echo images and morphology. And we are planning a lot of more things for you. We are organizing the fetal series. We had the first one already. We are going to continue this in the end of February, probably on 25th. Adults with congenital heart defect, cat lab. So we are planning a lot of good things for you. And one of the other things that we are going to continue to have is Dr. Gil Vernovsky's series. We are just waiting to continue that soon. Please type your questions on the Q&A chat box, and everybody's going to be very happy to answer your questions. So now with you, Dr. Gil Vernovsky. Thank you, guys.
Thank you all. First of all, Happy New Year to everybody. If we haven't seen you since the turn of the year, and greetings from Washington, D.C., which is much calmer now. It's wonderful to see everybody back in the Congenital Heart Academy. I wanted to also clarify two things, Grace, if that's okay. One is that there's both a chat box and a Q&A. Please put your questions in the Q&A, and that will allow all of the panelists to answer there, and we will stay on top of that. And I'll welcome all the faculty to check the Q&A box periodically to see if there are things that you'd like to contribute to make it somewhat of a live and interactive meeting, although still in the COVID pandemic, it's challenging. I hope that everyone is safe and starting to get immunized. This is a very, how many times can we say unprecedented or challenging times? It's been painful. And I think one of the things that has been a silver lining has been the development of this large family that we have now internationally sharing about congenital heart disease. Next Wednesday, and we'll be sending this information out probably tomorrow, we have partnered with some of our faculty and the Pediatric Cardiac Intensive Care Society to put on a 1-hour webinar through a LinkedIn connection called Live with Noel, but it's a 1-hour webinar on nursing retention in pediatric cardiovascular disease. It's not necessarily a topic like Epstein's and transposition and heart failure, but as everybody knows, if we don't have a good experienced staff that we can retain, it's hard to do the things that we want to do. So Patty Hickey, Darren Klugman, Melissa Jones, myself, and a few other people will be talking about that, and we'll get the information out shortly. That'll be at, let's see, 5 o'clock Central European time and noon Eastern Standard Time in the US. So without further ado, I want to introduce the chair of this session. I'm really excited to introduce Dr. Shri Deshpande, who works here at Children's National in Washington, D.C. We were fortunate enough to recruit Shri from the Children's Hospital of Atlanta about almost 3 years ago now. And Shri is just an incredible human being. He really does have it all. He is an expert clinician. He works in our intensive care unit for cardiac intensive care, for heart failure, mechanical circulatory support, transplant medicine, fantastic cardiologist. He's a great teacher. He's an academic researcher. He works with charitable organizations here in the United States, working with an organization called Enduring Hearts, who has been philanthropically dedicated to preserving the duration of organs after heart transplantation. So you can see he does it all. He's also the coolest guy I know. The thing that's come out of the pandemic for him has been this great ponytail. He is very zen. Nothing shakes him. And I'm really glad to introduce Shri, who will take it from here. Dr. D.
Thank you, Gil. Thank you. You are in a generous mood today. Thank you, Grace, Sasha, and Gil for the opportunity. It's a huge, huge honor to be able to put this together, coordinate this session. And obviously, I personally want to thank each and every one of the speakers that we have today. We really have an incredible group of speakers lined up today to share their knowledge, insight about heart failure. And I'm looking forward to the session on a personal level. I think it's also a session that's a little bit challenging because we wanted to make sure we are covering a session that's relevant to all, whether it's trainees, cardiologists, bedside people, intensivists, heart failure experts. So we're trying to gauge and keep the interest of everybody. But what is also challenging at the same time is that heart failure in pediatrics is such an understated and, to me, almost an underappreciated condition that we really need to hear it from the experts to get to gauge it really well. And we really haven't seen a better session dedicated to pediatric heart failure than what we'll have today. So I'm again very glad, thankful for everybody who's participating. And in the end, it's always a humbling experience to be able to share the stage with 400 people that are already online. So it's incredibly humbling personally. So let's get started with the session itself. The first speaker, for full clarification, it's 2 a.m. in Melbourne, Australia. So thank you, Robert Weintraub, for being our first speaker here. As most of the people in heart failure community are familiar with all of the speakers today, really. But just to introduce, Dr. Weintraub is a pediatric cardiologist at Royal Children's Hospital in Melbourne, Australia. He had his initial medical education at University of Sydney and fellowship at Royal Children's. He also trained in UK at Hartfield Hospital and in San Diego. For more than a decade now, he's been really the lead researcher, lead clinician for heart failure, transplantation, and pulmonary hypertension, I would say, in Australia itself, and has hugely contributed to the worldwide community. His research interests include cardiomyopathy, pulmonary hypertension, and has also put in a lot of effort developing the pediatric cardiac registries, both worldwide as well as specifically in Australia and New Zealand. It's a great honor to welcome Dr. Robert Weintraub, who will speak to us on pediatric cardiomyopathies, etiologies, and pathophysiologies. Thank you.
Thank you very much, Shri, for the kind words. Thank you also to you and the Academy for the invitation to participate in this seminar. I'm going to be discussing the etiologies and long-term outcomes of pediatric cardiomyopathy, and I have no disclosures. I'm going to start with some general comments about pediatric cardiomyopathy, and my talk really presupposes a working knowledge of common cardiomyopathy phenotypes. So I think, as everyone here knows, cardiomyopathies are a heterogeneous group of disorders with very varied presentations and varying outcomes. The middle panel in this slide shows some data from a cardiomyopathy registry that we started in the 1990s and has really turned into a longitudinal cohort study with nearly 25 years of follow-up. And it's a cumulative frequency histogram with the y-axis showing the proportion of patients with each cardiomyopathy phenotype and the x-axis showing the age of presentation. And you can see that for this group of children who are aged 0 to 10 in our registry, the peak age of presentation is in the first 2 years of life, with the exception of restrictive cardiomyopathy. And this still holds true even when you include children aged 10 to 18. So pediatric cardiomyopathies punch above their weight. They're the commonest cause of structural heart disease leading to sudden death in young people. They're the commonest cause of heart failure outside of infancy. They consume considerable amounts of hospital-based resources, and they're the commonest indication for heart transplantation beyond the first year of life. Before we get on to some specific cardiomyopathy phenotypes, I'll make some comments about pathophysiology, but I think Arianna is going to deal with this in considerably more detail than I am. Assessing left ventricular systolic function in children, particularly young children, and particularly those with advanced cardiomyopathy, can be challenging. Some of these children have very poor contractility, they have valvular regurgitation, their ventricles are underfilled and sometimes hypertrophic, and there's lots of room for measurement error. And the traditional indices that we've used, and in particular fractional shortening and left ventricular ejection fraction, are load dependent, they're poorly reproducible, and they're strongly related to left ventricular volume. Tissue Doppler imaging of longitudinal ventricular function is a very sensitive way of looking at both systole and diastole, and abnormalities can precede any change in obvious systolic function on imaging. but they're not that good at quantifying systolic dysfunction. Strain measures, on the other hand, particularly global longitudinal strain, are sensitive indicators of systolic dysfunction, and subclinical changes in strain have been found in patients who have a predisposition to familial dilated cardiomyopathy, presumably as a precursor to developing systolic dysfunction. And they've also been found in patients with dilated cardiomyopathy who've recovered. Now, diastole is a particularly complex part of the cardiac cycle. It consists of isovolumic relaxation, rapid ventricular inflow, diastasis, and atrial systole. And stages of diastolic dysfunction as graded by echo include impaired relaxation, which is associated with a normal left atrial pressure, pseudonormalization, in which left atrial pressure is increased, and finally pure restrictive disease, characterized by marked restrictive pathophysiology. Our adult colleagues are very good at assessing diastolic function with Doppler patterns of mitral and pulmonary venous inflow. And when you combine these with some simple imaging, you can develop some pretty sophisticated algorithms for grading diastolic dysfunction, which correlate well with invasive hemodynamics. And this is incredibly useful, for example, not only in looking at why patients are sick, but also making predictions, because diastolic dysfunction can clearly precede hypertrophy in hypertrophic cardiomyopathy. However, in young children, we're still not there yet. Precise quantification of diastolic function is difficult. There are issues of reproducibility and inter-observer consistency around certain echo parameters. And cardiac catheterization is still a frequent go-to for us for assessing hemodynamics, as well as for doing the other things we need to care for heart failure patients, such as calculating pulmonary vascular resistance and maybe obtaining diagnostic endomyocardial biopsies. Okay, so moving on to dilated cardiomyopathy. This is the commonest childhood cardiomyopathy. It accounts for around 60% of cases in our registry. As you all know, it's characterized by both left ventricular dilatation and systolic dysfunction, although the degree of dilatation may not be all that marked if it's rapidly progressive, for example, associated with fulminant myocarditis, and the degree of right ventricular involvement is very variable. In children, genetic, infective, and metabolic causes predominate. Systolic dysfunction obviously leads to low cardiac output, but the severity of associated diastolic dysfunction largely determines symptoms and the clinical course. The majority of young children certainly present with congestive heart failure, and to this point, adult heart failure therapies directed towards neurohormonal activation haven't been shown to influence important outcomes such as death and transplantation in children with dilated cardiomyopathy. This table on the left shows the common genetic causes of dilated cardiomyopathy, and you can see that this condition is characterized by considerable genetic heterogeneity. The prevalence in the second column is that of affected adults, and represented are cytoskeletal and sarcomeric proteins, nuclear proteins, ion channel mutations, and mitochondrial protein mutations. Yeah, my impression is, although I haven't seen a lot of this in writing as yet, is that titin mutations are somewhat less common as a cause of dilated cardiomyopathy in children, and certainly we see a lot of the other sarcomeric protein mutations. So what do we know about the outcomes for children? Oh, sorry, moving next on to other causes of dilated cardiomyopathy. There are many causes, as I said, infection and inborn errors of metabolism predominate, although we do see the full spectrum of conditions in this slide. And all of these conditions are now routinely looked for in cardiomyopathy workup protocols. Although this slide deals predominantly with dilated cardiomyopathy, inborn errors of metabolism, and in particular fatty acid oxidation defects, can also cause a hypertrophic or a mixed phenotype, and therefore get included in the cardiomyopathy workup protocols for children presenting with undiagnosed hypertrophic cardiomyopathy. So what do we know about the long-term outcomes of children with dilated cardiomyopathy? Well, here's some more data from our registry. Everything seems to happen in the first year. At year one, a little more than a quarter of the children had died or been transplanted. And after that, events happened at the rate of about 1% per year. So basically, if you get through the first year, your chances of having a sudden event reduce dramatically. Children who are aged less than 4 weeks, i.e. neonates, and those who are greater than 5 years old at the time of diagnosis tended to do worse. And poor prognostic variables included a lower fractional shortening Z-score at presentation, a failure to improve echocardiographic Z-scores during follow-up. Familial cardiomyopathy was associated with worse survival. Myocarditis, on the other hand, was associated with better survival and higher rates of reverse remodeling. And at long-term follow-up, if you did survive free of transplantation, then the great majority of subjects were not symptomatic and most were not receiving medical therapy. The Pediatric Cardiomyopathy Registry is a very large North American initiative that has enrolled thousands of patients, and they've looked at patients aged under the age of 18 and have produced fairly similar data for children with dilated cardiomyopathy, but they were able, because of their large patient numbers, to also look at etiology-specific outcomes. And children with neuromuscular disorders such as Duchenne muscular dystrophy tended to do worse, possibly because they died of other causes. Children with idiopathic cardiomyopathy also tended to do fairly poorly, worse than children with myocarditis, for example, whereas children with inborn errors of metabolism and those with malformation syndromes tended to do best, possibly because they were found on routine screening rather than presenting with congestive heart failure. And again, you'll note the fairly rapid drop-off for almost all categories of etiology in the first year after diagnosis. So moving on to hypertrophic cardiomyopathy, this is characterized, as you know, by unexplained left ventricular hypertrophy. It's much more heterogeneous in expression and has a diverse clinical course. There are no agreed diagnostic criteria in children. Our adult colleagues use a septal thickness or posterior wall thickness of greater than 15 millimeters, which might correspond to a Z-score of +7, but we tend to refer to hypertrophy as someone having a Z-score of greater than +2, so there is this disconnect between pediatrics and adults. The prevalence is around 1 in 500. Adult onset hypertrophic cardiomyopathy is generally considered to be due to sarcomeric gene mutations, and there are now more than 1,500 mutations described. Outflow obstruction is pretty common and is due to a change in the contour and dimensions of the outflow tract, as well as some anatomic variations in the mitral valve. Diastolic dysfunction is common, particularly in children, but also in adults, and may be due to a combination of hypertrophy, ischemia, fibrosis, non-uniform contraction, high intracavity pressures, and relaxation abnormalities. Inborn errors of metabolism and malformation syndromes are much more likely to present in infancy with heart failure. Sarcomeric hypertrophic cardiomyopathy can present at any age, right up until the 7th decade. And as illustrated on the right-hand panel, multiple non-genetic and genetic factors can influence both the expression and the actual penetrance of sarcomeric hypertrophic cardiomyopathy. In children, we have to consider non-sarcomeric causes, and these are represented in this table. You'll see that glycogen storage diseases in the form of Pompe disease are important players, along with Danon and PRKAG2 mutations. Anderson disease is not something that we particularly see in children. The mean age of presentation is in the late 20s, and neither is amyloidosis, but the rasopathies represented by Noonan or Leopard syndromes, Costello, and the cardiofaciocutaneous syndrome are big players and probably account for about 30% of all pediatric hypertrophic cardiomyopathy cases. And occasionally we see unfortunate children with Friedreich ataxia, particularly in late adolescence, but the age of presentation can be somewhat variable. So what do we know about long-term outcomes in hypertrophic cardiomyopathy? Well, these patients accounted for a little over 25% of our registry subjects. They presented in the first year of life. Heart failure was an uncommon presenting symptom. Noonan syndrome was present in around a third, and familial, at least a quarter of the cases had family history of hypertrophic cardiomyopathy. Again, things tend to happen in the first year. So the event rate was 14% at year 1 and 22% at 20 years. So the event rate after year 1 is less than 1% per year. Resting outflow obstruction was present in around half. The specific risk factors for death or transplanted include younger age at presentation, sporadic hypertrophic cardiomyopathy, Noonan syndrome, increasing posterior wall thickness, interestingly not septal thickness, and gradations of fractional shortening Z-scores that were in the low normal range. So when I refer to low fractional shortening Z-score, it's not necessarily someone with depressed function, but statistically, if you have normal rather than hyperdynamic function, then you probably have an increased risk. And a lot of things happen to these patients, certainly in that group of patients who are represented in our registry. Nearly a quarter of them had a myectomy, and a fifth of them have had an ICD implanted over the past 20 years. The Pediatric Cardiomyopathy Registry was again able to look at etiology-specific outcomes with a very large data set. And this graph shows nicely the impact of having 1, 2, or 3 risk factors. For example, if you have idiopathic hypertrophic cardiomyopathy and are diagnosed prior to the first year, prior to your first birthday, then if you're underweight, if you're very young at diagnosis, if you're in heart failure, or if you have an increasing left ventricular posterior wall thickness, these are all additive risk factors. And I think this graph shows beautifully the additive nature of these risk factors. And for example, if you go to malformation syndrome, such as Down syndrome, and again, if you're diagnosed early, have congestive heart failure, or have a minor reduction in your left ventricular fractional shortening, and if you have all 3 of these, then your risk of dying or being transplanted is around 50%. So moving on to restrictive cardiomyopathy, this has a shared genetic basis with hypertrophic cardiomyopathy. It can be due to sarcomeric and Desmond mutations, as well as those affecting calcium homeostasis within the sarcomere. Low cardiac output results from increased cardiac stiffness and reduced left ventricular filling. The presentation ranges from no symptoms, which is relatively uncommon in my experience, to overt congestive heart failure, exercise intolerance and syncope, and sudden death. We need to consider constrictive pericarditis and exclude that as a diagnosis. And in adult patients particularly, we need to think about amyloid, sarcoid, and hemochromatosis, but we might also go through this diagnostic workup in adolescents. It's not uncommon to have a mixed restrictive hypertrophic phenotype with a ventricle that's mildly hypertrophic, but also highly restrictive. The outcomes really have been obscured by the fact that these patients tend to fall into the hands of transplant physicians who look for any reason to transplant them, myself included. And but essentially, people who don't have hypertrophy, people who present with congestive heart failure, and people who have systolic dysfunction tend to have worse outcomes. Syncope increases the risk of sudden death. Arrhythmias, ischemic changes, and pulmonary hypertension are also associated with worse outcomes, and there is no proven medical therapy that is of benefit other than transplant. And finally, I'm going to finish with left ventricular non-compaction. This remains a somewhat controversial entity in the adult world, although I think pediatric cardiologists have accepted this as a real entity, as distinct from being a morphological overlay of other cardiomyopathies. But it can also be associated with normal function and abnormal loading conditions, for example, sickle cell disease. It can occur in elite athletes and in pregnancy. When pathological, it's considered to be a premature arrest of myocardial development during embryogenesis, and we all start off with spongy ventricles that basically condense in the latter part of the second trimester. Morphologically, it's characterized by trabeculations and recesses. It can be associated with a variety of cardiomyopathy phenotypes, and the phenotype can undulate or it can change with time. It has shared genetic causes with dilated cardiomyopathy, but is also associated strongly with Barth syndrome. Management tends to depend on underlying phenotype. So finally, this shows outcomes for all cardiomyopathies combined, and I've lined up the Pediatric Cardiomyopathy Registry and our registry on the left and right-hand panels respectively, and you see that the hypertrophs do best. The dilated cardiomyopathies and the non-compactions have intermediate outcomes. The non-compactions probably do worse than the dilateds because very few of them, if any, have myocarditis and therefore tend not to resolve. And with the restrictive cardiomyopathies, the discussion is really about the timing of transplantation. So thank you for your attention, and I highly recommend reading the Cardiomyopathy in Children scientific statement from the American Heart Association, which I have listed on this slide. Thank you for your attention.
Thank you very much, Dr. Robert. Thank you for being with us at this time. We know that it's late, and we really appreciate the amazing talk. So moving forward, and please, guys, make your questions on the Q&A chat box so we can discuss further this topic that is very interesting. And so moving forward, now we are going to have Dr. Shri. And this is a funny story. 2018, me and the leadership of my previous program from Brazil went to PCICS meeting in Miami. And then we were invited to Children's National dinner. We were there seated with a very cool guy, very, very cool guy. And we were chatting. It was an amazing night. Everybody had a lot of fun. Okay, a couple of months, and of course, he told his name, he introduced himself, but a lot of people, we really didn't pay a lot of attention on that. And then a couple of months later, I went to Children's National to close a deal with telemedicine from my previous hospital in Brazil to Children's National. We had an amazing partnership with Children's National. I highly recommend, guys. Telemedicine is something that helps a lot the programs. It helped a lot my previous program. So then I was booked. I was scheduled to have meetings with all the leadership from Children's National. And one of these mornings that I was in Washington, it was scheduled for me to talk to the director, the medical director of the transplant and the mechanical circulatory support. And when I entered the room, that was Shri. So that cool guy was really a serious guy that full of knowledge. We had a good time. And after that, we had a great partnership. He gave a couple of talks to my team in Brazil. We really appreciate that. I hope he can continue to help us there. And so now he's going to talk to us about heart failure and congenital heart disease. Thank you, dear.
Thank you, Grace. Again, thank you for the opportunity to do this. It really has been amazing. So following up on what Dr. Weintraub started, which is the discussion about heart failure in cardiomyopathy patients, we wanted to transition to heart failure in congenital heart population. This is a beautiful painting by Giovanni Lafranco from 1600. This is Saint Luca healing a dropsical child. And a lot of historians, including medical historians, think that this child probably has an Eisenmenger syndrome, probably had a VSD, and is suffering from terminal heart failure and has transitioned to Eisenmenger syndrome, and that St. Luca is healing him, which to me is an amazing depiction of congenital heart disease and heart failure. What we're going to talk today, other than this painting, is we'll talk about definition of heart failure in CHD itself. We'll talk a little bit about mechanism, pathogenesis, and then finish up and throughout the talk about clinical implication and some pointers. So let's start off with the definition that was put forth by an AHS scientific statement, which is dedicated to chronic heart failure in congenital heart disease. This is the definition in the AHS statement itself, and I will read it out to you because it's important. In physiologic terms, heart failure is a syndrome characterized by a state of pulmonary and systemic venous congestion and/or inadequate peripheral oxygen delivery at rest or during stress caused by cardiac dysfunction. When I read this statement, the missing piece for me was clearly the anatomy and the pathology of the heart failure and congenital heart disease itself. So a statement that speaks to this population somehow misses the point, I think. And I would like to present a modified definition for this, which would be the following, which is that it's still a heart failure syndrome, still with pulmonary and systemic venous congestion and or inability to meet the metabolic demands of the body caused by a structural or functional impairment of the cardiovascular system. So two things that are important to me in this, which is the addition of the structural part and changing cardiac function to cardiovascular system, because in congenital heart disease, as you all know, the entire cardiovascular system plays a significant role. So my apologies to the AHA for taking the liberty, but I think this is how I would put it. So let's transition to the mechanism of heart failure in CHD. To me, there are certain specific mechanisms that we could present this as. We could present this as pressure loading, volume loading, inefficiency, combined pathophysiology or combined mechanism. And as you can see from the Venn diagram, any of these components can overlap with any one of them. And this is the challenging and interesting part about heart failure in CHD, which is that you get these various mechanisms for it. How do we get here? There are very important genetic factors that lead us here. And more importantly, we don't stop at the diagnosis of congenital heart disease. There is a very important acquired component of heart failure in congenital heart disease. So let's review some of these over the next couple of minutes. Let's start off with examples of volume loading. This is probably the most common congenital heart disease mechanism for induction of heart failure. And common congenital heart conditions will lead to volume loading of the heart, either the right heart or the left heart. ASD, VSD, PDA are commonly diagnosed conditions, as well as specific conditions such as valvular regurgitation, AV malformations can lead to this. Here is an example of a large ASD leading to a volume load on the right heart. Here is an example of a VSD leading to volume loading of the left heart, and you can see the left ventricular dilatation there. Here is an example of mitral regurgitation. What you can see here is that the entire left heart, left atrium is dramatically increased. What happens in volume loading is that there is a constant burden of excessive volume on either the right or the left heart, leading to both atrial and ventricular enlargement, remodeling, pressure increase over time, and eventually cardiac dysfunction, heart failure. Let's talk about mitral regurgitation specifically when it leads to, when we think about just the example of what the pressure volume loops look like in this condition. And what you can see in a mitral regurgitation is that you've lost both the isovolemic filling as well as isovolemic contraction times here. Initially, the end systolic volume may be lower because of volume getting accumulated in the atrium rather than in the ventricle. But as heart failure ensues, you will see that this red volume loop will shift more to the right, and there will be an increase in the left ventricular volume, as well as dysfunction setting in. When we think about pressure loading of the heart, again, a common scenario in congenital heart disease, examples of right heart pressure loading conditions such as pulmonary stenosis, pulmonary vein stenosis, and mitral stenosis, and left heart pressure loading conditions such as coarctation of aorta or aortic stenosis. Here is an example of a coarctation of aorta, echocardiography, as you can see clearly here. Example of pulmonary valvular stenosis as an infant, aortic stenosis as an infant. And what does the pressure volume curve look like? This is what it looks like in aortic stenosis. There's a significant amount of pressure load after load on the left ventricle. And as is evident to you, the work that is involved in overcoming this after load causes a significant amount of myocardial burden on it, both from workload standpoint, metabolic demand standpoint, and eventually leading to what we call pathologic hypertrophy of these ventricles. Once the pathologic hypertrophy sets in, these heart or myocardias does progress to heart failure very, very quickly. Let's look at the next example, which is inefficiency. Inefficiency is a unique feature of congenital heart disease heart failure, which is present in and manifests as either recirculation, for example, AP collaterals that are seen here in the panel as an angiogram as well as a CT scan, valvular regurgitation, which I've shown you already, but a mitral regurgitation, for example, it's a very inefficient system. So a lot of the energetics are expended in pushing the blood from the ventricle into the atrium rather than into the outflow tract. So there's an inefficiency in this system. All of the left to right shunts are, again, inefficient systems, lead to heart failure. And then you can have additional myocardial insufficiency, that is because of myocardial injury or because of cardiomyopathy, as we saw earlier. All of these systems, again, create more work with less output. Just to give you a perspective, in a patient with Fontaine who has collateral burden, what has systematic reviews and studies have shown is that 43% of the pulmonary blood flow could be coming from these collaterals. And 35% of the cardiac index could be going into the collateral circulation. And again, as we said, this is inefficient circulation because oxygenated blood is going back to the lungs. So again, a very important mechanism for heart failure in congenital heart disease. Then you can have combined. As I mentioned, any of these lesions any of these mechanisms can overlap and give us combined heart failure. Probably the most important one is single ventricle circulations. Here is an example of a single ventricle hypoplast with a BT shunt. In this case, the right ventricle has pressure load because it's pumping against systemic circulation. There is inefficiency because oxygenated blood is going back to the lungs. And also there is volume load on the right ventricle because it is dealing with 2 times or 3 times the normal cardiac output load that it should be handling. So this is a combined lesion, combined mechanism of heart failure. Cardiomyopathy with mitral regurgitation is another good example of a combined mechanism of heart failure. What is another unique feature is that in a lot of congenital heart population, we expect the right ventricle to serve as a systemic ventricle. And it is important to recognize some pointers about right ventricle. It has a different origin than the left ventricle. It has very different transcription factors that manifest the proteins, including the sarcomeric proteins of the right ventricle. As you all know, the muscle fiber arrangement is very different than the left. It is arranged in 2 layers rather than 3. There is a superficial layer, circumferential, and a deep longitudinal layer. And more importantly, mechanism of contraction in right ventricle is predominantly longitudinal shortening, rather than a very complex and efficient way of helical shortening in the left ventricle. Right ventricle also is designed to handle preload, but it's extremely sensitive to afterload. So right ventricle cannot handle afterload lesions. So pressure loading the right ventricle leads to earlier failure. Left ventricle, on the other hand, can handle afterload, but is poorly designed to handle preload. So volume loading a left ventricle leads to heart failure sooner. From here, let's move on to a minute or two about the genetics that lead us to this mechanism of heart failure itself in congenital heart disease again. There is a very significant overlap between the genetics of congenital heart disease and heart failure itself. And what we're recognizing now is that this genetic overlap not only manifests as congenital heart disease, but also manifests as myopathy. We know monogenic reasons for development of congenital heart disease, as we know in patients with Turner, Down syndrome, and all the other congenital genetic syndromes that have associated conditions with congenital heart disease. What is also increasingly being recognized is that there's a shared genetics between these genes responsible for producing congenital heart disease and development of cardiomyopathy. And here are some examples of candidate genes in congenital heart disease that eventually manifest as cardiomyopathy also because of their downstream impact. This is an important area of research and an important area of both diagnostics as well as therapeutics for this particular lesion. I wanted to give a very specific example of 2 transcription factor genes, GATA4 and 6. These have been identified for normal embryonic development of the heart itself. We know that mutations of GATA4 and 6 lead to familial congenital heart disease. But in normal physiologies, these transcription factors are responsible for sarcomeric proteins, including alpha and beta myosin heavy chain, which are integral to the contraction of the heart itself or the myocytes itself. We know that they also are responsible for regulation of natriuretic peptide in the heart, and we are all very familiar with the role of these. And they also influence the anti-apoptotic gene BCL6. And what is well established is that mutations in GATA4 particularly affect the functioning of BCL6. Now, anti-apoptotic gene function is responsible for maintenance of mature cardiomyocytes. And so once you have a loss of function or a mutation in this gene, it leads to early apoptosis and leads to early heart failure. So as you can see by using these examples, that GATA4 and 6 not only have roles in normal embryonic development, but mutations of these can lead to congenital disease. Mutations can lead to abnormal sarcomeric protein, as well as abnormal apoptosis and leading to heart failure. Lastly, let's talk about the acquired part of this mechanisms. In congenital disease, there is an important acquired pathology. This comes from cyanosis, the impact of cyanosis on a developing heart, as well as perioperative hemodynamic instability and the treatment that we have to use for this. This causes myocardial injury on top of the congenital disease. Further, surgical techniques, trauma, myocardial protection during bypass, and myocardial ischemia and reperfusion all have known to contribute further to myocardial injury. So even though we have seen tremendous development in the surgical techniques, and we have a surgeon in our speakership today, but what we know is that there is still room for improvement as far as myocardial protection is concerned and myocardial ischemia perfusion is concerned. Further down the line, there are post-operative hemodynamic instability and the treatments, including the use of catecholamines, that may contribute to this injury again. And we don't stop at operating or intervening once. Some of these hearts go through repetitive myocardial injury and or procedures that can again contribute to the myocardial injury again. This is just an example of what happens to a heart after going on bypass and myocardial reperfusion injury. You can see coagulation necrosis, you can see fibrosis, contraction band necrosis, as well as calcification, all within just one exposure to myocardial ischemia and reperfusion. What happens as a result of this combined pathophysiology of heart failure is that these genetic factors that we just referred to lead to congenital heart disease, lead to molecular and metabolic changes, and lead to congenital heart disease, heart failure mechanisms all combined. But on top of that, we have post-transcriptional changes or epigenetic modifications, as well as our interventions. All of these interact with each other and contribute to heart failure and congenital heart disease. And lastly, I wanted to share some implications about this. There are significant implications because congenital heart disease often carries comorbidities. So as we all know, DiGeorge syndrome, Down syndrome, etc., have all congenital heart anomalies with them, have other abnormalities such as pulmonary function abnormalities, renal abnormalities, and immunologic abnormalities that can contribute to the heart failure itself, as well as the morbidity of the patient. I'm going to skip this part. And then lastly, what we know is that preoperative optimization in hemodynamics, oxygen delivery status, is really critical. Postoperatively, care focusing, rather than focusing on short-term outcomes, we really need to focus on the long-term outcomes of these patients. We need to develop better inotropic agents so that we can overcome the current limitations of both preoperative and postoperative care for these patients and inducing more injury to these patients. We have to really use cardiac catheterizations, MRI, whatever we can to early assess impact of residual lesions, because that has been shown to impact long-term outcomes. And early interventions for these residual lesions are necessary. And lastly, what I leave at, which is that genetic therapies may hold the key to future. If we can better understand both the genetics of congenital heart disease, heart failure, as well as the epigenetics of it, we may be able to better address both congenital heart disease as well as the heart failure that ensues from it. With that, I want to summarize this, that there are various pathologic types that lead to congenital heart disease. There is interplay between genetics, the phenotype, as well as the acquired factors, as summarized in this figure. There are important comorbidities that we should remember for these patients. Assessment and management require specific considerations, and there is tremendous need for research in this area. So again, I want to thank the organizers. Thank you, Grace, Gil, and Sasha. And we'll happily take questions at the end of this session. Thank you all for listening in.
Thank you, Shri. Amazing talk, really. And regarding the genetic association in these patients, this is something that's very common here in the Gulf region. So we see a lot of patients with anatomical congenital heart defect and with myocardial diseases. This is very, very frequent here. So now we are going to move forward. We are going to talk about imaging in heart failure with Dr. Arianna di Molfetta from Italy. She is a biomedical engineer and medical doctor. As an engineer, she developed mathematical models of the cardiovascular system dedicated to pediatrics and to VAD. Her clinical activities is mainly focused on VADs and on cardiac catheterization. Thank you, Arianna. Grazie.
Okay.
You need to share your screen again.
Yeah. Sorry.
All looks good. All looks good at this time.
Yeah. Yeah, but it is not correct again. Sorry.
No problem.
Okay. I think now it's going to work. Okay. Okay. Can you see the slide?
Yes, just need to go to, now it's on.
Perfect. So first of all, let me thank all of you for the kind invitation. It's a great honor and a pleasure to contribute to Congenital Heart Academy. As I told to Sasha several times, I'm always really excited and curious when I receive your email just to know what's going on. And every day before going to the hospital, I used to enjoy a part of a webinar on the YouTube channel. So thanks, it's an honor. I also would like to thank my colleague and friend Roberta Jacobelli, who is online now, because this is a, let's say, a forehand presentation about imaging in pediatric heart failure. So thanks, Roberta. As also Shri said, we can have pediatric heart failure because of ventricular pump dysfunction, volume overload, and pressure overload. In this presentation, we will mainly focus on ventricular pump dysfunction, as also the volume overload and pressure overload was already analyzed by Shri in the previous presentation. So this presentation will be mainly focused on echocardiography, which is for sure the cornerstone of the initial evaluation of these patients. We should remind that as children are not small adults, all the measurement of the cardiovascular structure should be expressed as Z-score, normalizing them by the body surface area. So this will be the contents of the presentation and the approach that we will follow in the evaluation of pediatric patients affected by heart failure by echocardiography. First of all, we will focus on the evaluation of the left ventricular systolic function. As you probably know, traditionally we can use a linear approach by the use of the M mode, and so the evaluation of the left ventricular and diastolic and then systolic diameter, and therefore the shortening fraction. But we can also use a volumetric approach. So with the Simpson biplane method in 4-chamber apical view, we can, of course also in 2 chambers view, we can evaluate the left ventricular and systolic and diastolic volumes and the ejection fraction, or we can use a modified method by the introduction of the short axis area and the length. More reliable measurements of the left ventricular volumes and ejection fraction are given by 3D echo, whose measurements are more accurate and closer to MRI data, which are the gold standard, only with a slight underestimation of ventricular volumes. Let's continue speaking about the left ventricular diastolic function. So there are several parameters to evaluate it, such as the left atrial size, the mitral inflow velocity profile, and the deceleration time. But both these two latter indexes are preload and heart rate dependent. So in pediatric patients with very high heart rate, we can have an EA fusion. We can evaluate the isovolumic relaxation time, the pulmonary vein brain Doppler pattern, and also we can use the TDI approach. Let's speak about the right ventricle. Because of its retrosternal position and because of its shape, it could be more difficult to evaluate the right ventricular function by echo, but there are several traditional indexes such as the right ventricular end-diastolic diameters evaluated at the basal and at the mid-cavity level, the right ventricular end-diastolic length, and the right ventricular end-systolic and end-diastolic area to evaluate the right ventricular fractional area change. By the M model, we can evaluate the tricuspid excursion, so the so-called TAPSE, and we can also use Doppler indexes such as the systolic pulmonary arterial pressure, the DPDT that can be calculated also for the left ventricle, the inferior vena cava collapsibility index, the TDI, and the isovolumetric relaxation time. More recently, also for the right ventricle, it is possible to use the 3D echo with a more reliable and more accurate assessment of right ventricular volumes and function, also in comparison to the gold standard, which again is the MRI, and only with a slight underestimation in comparison to the MRI. We cannot speak about the strain because in the last years the strain starts to play an important role also in pediatrics. So these are two very nice work. Evidencing the references value for the 2D and 3D speckle tracking echocardiography in children through meta-analysis. In particular, the global longitudinal strain is defined as the length change of the myocardium parallel with the endo, mid, or epicardial contour. And it was demonstrating that the global longitudinal strain is an additional prognostic index also in pediatric heart failure, and also that it correlates with the edema amount and localization at MRI. I do really appreciate that Shri spoke about the pressure volume loop, because I also would like to speak about this topic. In fact, when we evaluate patients with heart failure, it is not only important to evaluate the ventricular function, but also the efficacy of a specific pump to eject the blood into a specific arterial bed. This concept is the concept of ventriculo-arterial coupling, the VA coupling. So if in the pressure volume plane we trace the end-systolic pressure volume relationship, whose slope is the systolic elastance, which is a preload independent index of the systolic performance of a ventricle, and is simplified as the ratio between the end-systolic pressure and end-systolic volume. And if we trace the other line whose slope is the arterial resistance, which represents the impedance of the arterial bed and is defined as the ratio between the end-systolic pressure and the stroke volume, we obtain an intersection point. This intersection point is the working point of the whole system, the ventricle and the arterial bed, and it is the VA coupling, and it is defined as the end-systolic volume divided by the stroke volume, so can be evaluated by echo. It should be underlined that concerning the systolic elastance, the gold standard is the invasive evaluation by the conductance catheter, but there are several single bit approaches proposed in literature to estimate the systolic elastance also by echo. And several authors reported some results in pediatrics. For example, Capone et al. Demonstrated that in pediatric patients with dilated cardiomyopathy, we have a lower systolic elastance, a higher arterial elastance, and a higher VA coupling in comparison to healthy subjects. In the work of Jacobelli, they demonstrated that the use of levosimendan could improve the VA coupling in pediatric patients with single ventricle physiology after surgical palliation. And again, the group of the Bambino Gesù Hospital demonstrated that also after the LVAD implantation, there's an improvement of both left and right VA coupling. Let's focus on specific cardiomyopathy now. Concerning the dilated cardiomyopathy, there are several echocardiographic parameters which are fundamental, as for example, the left ventricular and diastolic Z-score, which correlate with cardiac events, the risk of transplant, and also the restoration of normal function. And concerning the 3D and the 3D strain, they are the 3D strain is associated with left ventricular dysfunction in children with dilated cardiomyopathy, but also in children after heart transplantation, even in the presence of normal ejection fraction. And concerning the hypertrophic cardiomyopathy, the most recent update of the 2020 guidelines, the American guidelines, again underline the important role of the echocardiography in patients follow-up, in the patient screening, and in patients' parents screening. And also the echocardiography plays a very important role for the sudden cardiac death stratification, especially focused on the thickening of the interventricular septum and on the functioning of the left ventricle. It is very important in these patients also to assess the diastolic function, because it correlates with any adverse clinical events. And also, as demonstrated by published in JASA in 2020, also in pediatric patients with hypertrophic cardiomyopathy, the exercise stress echo can be performed safely and served as an effective tool to identify the lowest risk patients for cardiac outcome. This strain can play an important role also in hypertrophic cardiomyopathy, because we know that generally in these patients the systolic function is preserved, but the GLS can be altered because of fibrous disarray. So the GLS is more sensitive than the ejection fraction in the identification of ventricular dysfunction also in this type of patients. Some innovative indexes are the wall shear stress and the energy loss that can be evaluated by echocardiography, and was demonstrated to be altered in pediatric patients with dilated or hypertrophic cardiomyopathy in comparison to healthy subjects. So our group focused a lot on imaging and echocardiography, in particular in LVAD patients. So I would like to present you some results of about 50 pediatric patients undergoing a Berlin-Art X-core LVAD implantation with an average age of 10 months and an average weight of 6 kilograms and an average LVAD staying of 150 days. As you can see from these cartoons, we observed that after the LVAD implantation, we have a reduction of the left ventricular volumes, but unloading decrease over time. And after the LVAD implantation, we observed a progressive enlargement of the right ventricle. Concerning the biventricular function, we observed that after the LVAD implantation, at the short time after the implantation, we have an improvement of the ejection fraction, the right ventricular fractional area change, the left ventricular global longitudinal strain, and the right ventricular free wall strain. But this improvement decreased over time. So, for example, you can see an example here. This is a patient before the LVAD implantation, so with a dilated left ventricle and severe mitral regurgitation. Here is after 15 days after the LVAD implantation, so with a good unloading and no mitral regurgitation. And here is 45 days after the LVAD implantation with the recurrence of the mitral regurgitation and left ventricular dilation. We also evaluate our patients studying by echo the functioning of the Berlin-Art chambers, valves and chambers, and in particular we observed that we have a mild regurgitation, in 14 inflow and 21 outflow valves, a moderate regurgitation in 5 inflow and 3 outflow valves. With this method, we can also study the interaction between the native heart and the pump, and in particular the beat phenomenon, which is a disturbance due to a concomitant opening of the aortic valve and of the outflow valve cannula. So this is the most frequent pattern in which we can observe here the normal opening of the VAD valve, the closure of the VAD valve, and here a very short in time opening of the VAD valve, which is due to the beat phenomenon. Here is the beat phenomenon in the case of patient's atrial fibrillation, and here is the beat phenomenon in the case of cannula tamponade with the fluttering of the Berlin heart valve. In this specific case, sorry, I have the audio, okay. In this specific case with the cannula tamponade, we also observed a severe regurgitation of the inflow cannula of this LVAD with a recycling of the blood into the left ventricle, and we observed by the TEE echo that it was due to cannula compression because of suction. So as we replaced correctly the cannula, we restored the normal flow into the cannula and normal flow into the also the VAD valve. Here we observed in this other case a severe regurgitation of the inflow valve of an VAD with recycling into the right atrium. In this case, changing the VAD setting, it did not restore the normal functioning, so we substituted the VAD to the patient. So we sent the VAD to the manufacturer, and they confirmed that there was a valve mechanical alteration. And finally, in these patients, we observed clinically and also by echo an alteration of the membrane movement, and changing the VAD setting, it was not possible to restore the normal membrane functioning. So we substituted the device to the patients, and we performed a CT scan of the device, observing a detachment of the 3-layer membrane in comparison to a normal functioning chamber. Finally, it is important the use of echo during the LVAD weaning, because for all the phases of the weaning, we should verify that the left ventricular and diastolic diameter Z-score remain lower than 2, the left ventricular ejection fraction remain higher than 45%, and that should be non or mild regurgitation of any cardiac valve. Finally, just a very few words on MRI, CT, and 3D printing. The MRI plays an important role because it is free of radiation. It is the gold standard for the assessment of ventricular volumes and flow. It is not operator dependent and not influenced by patient's acoustic window, while its main limitation is in the presence of metallic artifacts, and sometimes we need for sedation, and it could be difficult for pediatric patients because for noise, because of big breath control, and because of the duration of the exam. But anyway, it is for sure the gold standard for the evaluation of ventricular volumes that can be detected manual or semi-automated by segmentation of the endocardial borders for every slide, which thickness is typically of about 6 to 10 millimeters and is captured 25 to 40 times during the cardiac cycle. If we trace an additional epicardial border, we can also evaluate the ventricular mass, and we can also evaluate the strain with higher spatial resolution in comparison to echo, but lower temporal resolution in comparison to echocardiography. We can evaluate the 4D flow with a spatial resolution of 1.5 to 3 millimeters and the temporal resolution of 30 to 40 milliseconds. And we can characterize the tissue, for example, the myocardial fibrosis thanks to the late gadolinium enhancement, the myocardial inflammation in the T2 sequence, and the myocardial stress perfusion administrating coronary artery vasodilator and then the gadolinium, and seeing that this region of hypoperfusion are darker during the exam. Concerning the CT, it plays maybe a less important role in pediatric heart failure, because we would like to preserve our patients to radiation exposure, even if we have low radiation dose exposure techniques. But the main advantages is that the easy access, the short examination time with high imaging resolution, the possibility to study patients with metal bars and after device implantation, the possibility to detect vessel damage and calcification, the possibility to study small structure and also coronary arteries thanks to the ECG gating. And finally, more recently, the 3D printing technique was applied also on pediatric heart failure, as for example, in this paper published on JACC heart failure, it was reported the 3D printing on the left for a patient affected by Epstein anomaly, and on the right to patients with congenitally corrected transposition of the great arteries treated with LVAD. So thank you for your attention.
Excellent. Thank you, Arianna. That was a great talk, and I know we'll have some questions. We already have some Q&As that we'll answer, and some during the break. I have the great privilege and honor of introducing our next speaker, Dr. Aamir Jeewa from Sick Kids in Toronto. It's a small world in heart failure circles, at least here in North America, and we see each other a lot. I have the great opportunity and privilege to work with him and talk to him and share thoughts during meetings. So I'm looking forward to this talk, Aamir. Aamir, just for introductions, received his medical degree from Dublin, Ireland, then went on to do residency here in New York, Buffalo, New York, and then did cardiology fellowship as well as the heart failure transplant fellowships in Vancouver and then Sick Kids in Toronto. His first faculty position was at Baylor College of Medicine in Houston, Texas, where he was a transplant heart failure cardiologist and also led their VAD program. He also led their advanced training fellowship program there for heart failure transplantation fellowships. And then in 2018, moved to Sick Kids back again, this time as the section head of cardiomyopathy and heart function program within the division of pediatric cardiology, and is associate professor of pediatrics at the University of Toronto. His research interests include cardiomyopathy, ventricular assist devices, myocardial recovery, and heart transplantation. He is an active member of the PHTS, the transplant organizations, as well as just the clinical discussion forums that we have where we share our experiences. Welcome, Aamir. Thank you for giving the talk.
Thanks, Shri, for that introduction. Hope everyone can hear me okay, and I hope you're all well wherever you are in the world today. Just going to share my screen, make sure that looks good. Oops. Okay. Hopefully everything looks okay on your end. Today I'm going to discuss the medical management of chronic heart failure in children. These are my disclosures. So going through some learning objectives, we'll discuss the impact of chronic heart failure in children, discuss some of the current guideline-directed medical therapies, and then what's on the horizon or already here in some ways. So what is chronic heart failure? It's a very old entity that has been described as far back as ancient Egypt. Dropsy, as it was referred to in the 18th century, was synonymous with congestive heart failure and described the state of fluid overload that required an emptying of the system by bloodletting, i.e. by venesection or by leeches. Chronic heart failure is a progressive syndrome that results in poor quality of life and places an economic burden in the healthcare system. And chronic heart failure can be the sequelae after episodes of acute decompensated heart failure or the primary presentation that is slow in development. This infographic just depicts the current problem of heart failure in Canada. I think we're all sick and tired of talking about pandemics, but heart failure is a growing epidemic. It costs more than $2.8 billion per year. Heart failure is the third most common cause for hospitalization in Canada. And 1 in 5 patients with heart failure are readmitted to hospital after 30 days. These are obviously pretty detailed adult numbers. So what about the pediatric heart failure experience, I guess? Deshpande and Joe Rosano published this paper in 2013 looking at the Pediatric Health Information Services database, which is essentially the insurance database in the US. And they were able to show that the cost of pediatric heart failure that is associated with an inpatient admission is around $1 billion. Congenital heart disease represents a substantial portion of this, as Shri highlighted earlier in his talk as well about the problem of congenital heart disease and heart failure. And 10 to 14% of single ventricle admissions are complicated by heart failure as well. Higher percentage of heart failure admissions are also among patients who are less than 1 year of age. And the graph there just shows the discrepancy between hospital charges in pediatric heart failure patients versus adult counterparts. So we recognize the problem is big and expensive. How do we monitor children with heart failure? Well, we're all well versed in taking a history and physical exam, but it's important to assess the appropriate weight gain and development. We use echocardiography and other cardiac tests routinely in addition to biomarkers, exercise and functional testing, and we apply varying types of heart failure scores to help with risk assessment and prognostication for our patients. How do we manage chronic heart failure in children? Well, for the most part, we leverage the large amount of adult data and apply that experience to a pediatric group. This roadmap is from the Canadian Cardiovascular Society's Pediatric Heart Failure Guidelines, which shows the pathway that a patient presenting with heart failure can navigate. After the initial acute episodes, there's a stabilization phase, which often involves the conversion from IV to oral medications, especially diuretics, initiation of systemic vasodilators, optimization of nutrition, and then hopefully, if everything is progressing well, we're able to move towards a steady state or ambulatory phase. However, keeping in mind that periodically checking for measures of clinical deterioration is important, as patients can have steps backwards or escalation requirements needed to advance their level of support. This treatment algorithm is from the Canadian Cardiovascular Society as well, and it highlights the adult heart failure approach to the assessment and initiation of medications for those with symptoms and reduced ejection fraction. What I want you to take note of is that the diuretics span across the entire algorithm in conjunction with other therapies, placing a high degree of importance on decongesting a patient. And if we follow our colleagues from the 18th century, we recognize that emptying the system is very important. And instead of leeches, we use commonly used diuretics these days, loop diuretics, thiazides, and aldosterone antagonists. Of special note is that aldosterone antagonists also have been shown to improve survival in congestive heart failure patients by affecting the renin-angiotensin aldosterone system and subsequent effect on myocardial remodeling and fibrosis. And so to further place emphasis on decongestion, the adult heart failure experience shows that 1-year mortality is influenced by elevated wedge pressure, low sodium, LVEDD size, and interestingly, cardiac index did not influence mortality. And so I think it's important to highlight that the decongestion process in a patient shouldn't be delayed. It should be started as soon as possible if they come to the emergency room in an acute decompensated state. And as well, then in the long-term management, the requirement of intermittent diuretics may also be useful in keeping patients out of hospital. And I won't go into detail about this, but we also need to be aware of the impaired diuretic responsiveness or diuretic resistance factors as well too. And these can be multifactorial, but something to keep in mind. Now we're going to move a bit further from the 18th century, and one of the oldest congestive heart failure therapies is digoxin. It comes from the foxglove plant and is a potent sodium potassium ATPase inhibitor. In the setting of chronic congestive heart failure in adults, digoxin use decreased the rate of hospitalization and improved quality of life, but not survival. And similarly, there's a lack of pediatric data as kind of a consistent theme you're going to hear. And the use of digoxin is also quite controversial. I think of it more like a religion. Either you believe in it or you don't. Now we're getting back into the 90s, and commonly used medications include ACE inhibitors. Captopril is typically used for infants, and other long-acting agents like enalapril, lisinopril may be more appropriate for older patients, especially with those with some adherence issues. Caution is advised in the first 4 months of life because renal dysfunction is more common and up-titration should be carefully monitored. These are blood pressure lowering medications, so watching the systolic blood pressure is important. And a creatinine rise of greater than 50% over baseline may require reassessment of fluid balance and diuretic therapy in consideration for dosage reduction or withdrawal of ACE inhibitor therapy. And for those who can get pregnant, it's important to keep in mind that ACE inhibitors are also teratogenic in their effects. This is the SOLVED trial data from the 1990s, and it's published in the New England Journal, again showing in over 2,500 adult patients with heart failure how enalapril had a lower mortality compared to placebo. And again, one of the pieces of information that we use to leverage into our pediatric patients as well. Moving the story forward, the next big group are beta blockers. And there's been multiple studies that have conclusively shown that improvement in left ventricular function, symptoms, and survival in adults with symptomatic systolic left ventricular dysfunction for those treated with beta blockers. And it's also entered into pediatric heart failure guidelines as well. The recommendation is based on the premise that patients are willing to accept a relatively low rate of side effects for potential clinical benefits in the absence of conclusive evidence for benefit. And again, looking at the adult data, this is the study by Milton Packer and published in the New England Journal in early 2000. And it compared carvedilol to placebo, and again, in over 2,000 adult patients. And again, this graph shows that there was a survival benefit this time in patients on carvedilol compared to placebo. Again, you're not going to find similar data like this in the pediatric population. We do have experience with carvedilol in a pediatric drug trial. And so the pediatric carvedilol study, which included a smaller number of patients, obviously, it was about 160 patients, 100 in the carvedilol arm and about 55 in the placebo arm. This study was unable to show a similar strength and efficacy, but this study had a much smaller numbers, as I just mentioned, and as well, it included a heterogeneous group of children with both single and biventricular disease, which we know are, as we've just heard from Dr. Deshpande, is afflicted by different types of heart failure as well. And so in summary, this chart depicts the stepwise approach to applying these medications that are most commonly used in chronic heart failure in children. And as you can see, that starting with ACE inhibitors, introduction of beta blockers, and then aldosterone antagonists has kind of been the approach that we've taken on for quite a while, with the intermittent and pulsed use of diuretics that go across the whole spectrum. But how are we doing in the real world with respect to ACE inhibitors and beta blocker practice patterns? This study by Brady Moffitt and Jack Price again delved into the Pediatric Health Information Service database and showed that 1,700 children with heart failure, in those, the beta blockers were prescribed on discharge in 37% and ACE inhibitors in 70%. So we're obviously better with ACE inhibitors than we are with beta blockers. Those discharged on a beta blocker and ACE inhibitor at discharge were most likely to be on furosemide, spironolactone, and digoxin. And there are significant institutional provider variability for prescribing heart failure meds, especially beta blockers. You can see in the graph there that over time, the practice pattern for prescribing beta blockers did improve over time. And perhaps that's influenced by the strong adult data that has emerged over that similar time period. So what's new with regards to heart failure medications? Well, perhaps not new for adult heart failure, but still not with widespread use in children. Ivabradine is a funny current channel inhibitor and essentially works to reduce the heart rate with a less profound effect on blood pressure compared to beta blocker. In adults, the SHIFT trial had 6,500 symptomatic heart failure patients with a low ejection fraction. They were able to show a cardiovascular mortality or heart failure hospitalization rate, which was lower in the ivabradine group versus placebo. And now it's considered one of the recommended additional therapies in most heart failure guidelines. There is a pediatric data, but it's small, or I should say few in number. The study by Bonnet et al. Looked at 116 pediatric patients on ivabradine, and the primary endpoint was a reduction in heart rate, and 70% of children were able to achieve that. And as well as the secondary endpoints were some improvement in ejection fraction in comparison to those on placebo. Again, small study, but still some evidence that there is usage of ivabradine in our patients. And moving that story even further along is we now have a new class of medications known as ARNIs, or angiotensin receptor blocker and neprilysin inhibitors. This combination drug aims to promote natriuresis and as well as blockade of the renin-angiotensin aldosterone system. The large Paradigm HF study, which included over 8,000 adults with symptoms, as well as reduced EF, were on, as the drug is known as LCZ696, or Entresto, which is easier to say, versus enalapril. And you can see that it blocks neprilysin, which then allows for more natriuretic peptide to float around and provide natriuresis, in addition to blocking the angiotensin receptor. And as you can see on the composite outcome graphs here, the death from cardiovascular causes, death from any cause, and hospitalization for heart failure were all reduced in the Entresto group versus enalapril. An exciting piece of news is that the pediatric ARNI study, Panorama HF, just completed enrollment last month. And so we would hope that there will be some very interesting data to come from this about a year from now, since the last patients were just enrolled last month. And now a class of medications that truly is lacking in pediatric data, whether you're an endocrinologist or a cardiologist, are the SGL2 inhibitors. These are sodium glucose co-transmitter 2 inhibitors. There is quite a good bit of adult data on this, over 4,000 adults with, again, symptomatic heart failure receiving an SGL2 inhibitor versus placebo. And this again showed a reduction in death from cardiovascular causes, even in those with or without diabetes. And so I think this is also going to be an emerging treatment therapy or treatment mode that removes just from our usual targets that we've been used to in treating heart failure. And again, similar to those other graphs, again, the composite outcomes do show reduction in heart failure hospitalization, reduction from death from cardiovascular causes, and death from any cause as well. And Dr. Butler might go into this a bit more detail, but this was recently published in Circulation, looking at the modulation of the 5 pathways of heart failure, the angiotensin pathway, norepinephrine, aldosterone, neprilysin, and SGLT2, and then using different medications to approach the different pathways with the addition of additional therapies. And so perhaps we need to look at a change from our traditional approach. Instead of the stepwise approach that I showed earlier, we possibly need to consider a multifaceted or salvo approach with starting these medications, approaching all the different targets, not necessarily at stepwise, but all at once with lower dosages, and then working our way up to targets. To go beyond medications, we may also want to consider treating desynchrony with cardiac resynchronization therapy. The adult cardiac resynchronization data is very convincing in reducing mortality in those with heart failure, low EF, left bundle branch block, and symptoms. Similar findings have yet to be seen in children, though, and you can see the indications are, as just mentioned, a wide QRS complex, the lower ejection fraction less than 35%, and then NYHA class 2, 3, and 4, and they have to also be optimized on guideline-directed medical therapy as well for a class 1 indication. Now, by convention, we typically use inotropes for the treatment of acute decompensated heart failure. However, a well-established mode for chronic heart failure is using home inotropes, and probably milrinone being the one with the largest experience to date. With smaller CAD pumps, or these delivery pumps for home use, and durable PICC lines, many patients can be well supported for months as either bridge to transplant or as long-term palliation. And there are many reports across North America for this usage. One of the largest is this study published by the St. Louis Children's Group in over 106 patients with home milrinone with a very low death rate overall. Now, we've all heard the common saying that prevention is the best medicine. So perhaps we shouldn't just be looking at better drugs, but also better ways to monitor our patients with heart failure exacerbations. There are a number of smart devices, apps, and tools that are paving the way for more sophisticated and savvy ways to monitor patients, especially remotely. And by keeping patients out of hospital, maybe the most powerful way we modify long-term heart failure outcomes. You can see there are novel biomarkers. There's these small CardioMEMS devices that can sit in the pulmonary artery and give you continuous pulmonary artery pressure measurements. And as well as machine learning tools to help do more sophisticated risk prognostication methods for our patients. And lastly, but equally as important as everything else in treating heart failure, is the aspect of palliation and establishing goals of care. We know that as heart failure admissions become more frequent, the trajectory of organ failure may eventually lead to death. And early and active involvement with palliative care services can truly help patients and families be prepared for all forms of the outcomes that they are facing. And so in summary, chronic heart failure in children is a growing problem and will represent further stress on healthcare systems in the future. The medical management of chronic pediatric heart failure leverages the large adult data, but that should not stop us from continuing to study children. There are pediatric specific challenges that are related to size, age, and the etiology of heart failure. And new medications, more importantly, novel ways to monitor heart failure in children may have the biggest impact in long-term outcomes. Thank you.
Thank you very much. Amazing talk. I'm sure everybody learned a lot from you, and hopefully we are going to rethink the way we treat chronic heart failure in children. So now, Shri, we are going to a little bit of discussion, right? So this is a break, guys. There's a lot of more interesting talks after this 10-15 minute break, okay?
Absolutely. And just to highlight again, to hear from our surgical colleagues, it's important for heart failure standpoint. So I'm looking forward to that discussion. We have a cardiogenic shock talk coming on, pharmacology of acute heart failure, which will be very, very important and practical. And then lastly, rather than teaching each other, it is really important to learn from the adult colleagues, the big brothers, so to say. And so we really are blessed to have Dr. Javed Butler amongst the speakers today, who is a world expert in adult heart failure. And I'm looking forward to hearing his thoughts as far as his perspective, as well as where the field is going. So I look forward to that. Before we get that, there have been quite a few questions. I wanted to start off with you, Aamir, if that's okay. There have been questions about thoughts in terms of prescription ordering. When do you want to use an ACE inhibitor versus an ARNI? Is there a specific patient cohort, or is there any advantage of one over another?
It's a very good question. I think initially when we looked at some of the adult experience, and I think Dr. Butler's on as well too, the initial approach, and at least by a Canadian guideline standpoint, was to use an ACE inhibitor first, and then if you saw no improvement or no change in ejection fraction and symptoms, essentially no improvement in your patient, then to consider switch to an ARNI. I think there is some paradigm shift going on, and that perhaps targeting these receptors a little differently and maybe moving towards initial ARNI use is feasible and completely acceptable, and maybe the way we move in the future. I guess as a practicalist, I also think about cost, and ARNIs are much more expensive than generic ACE inhibitors, especially if we're talking about resource limited places around the world. And so I think it's also important to use what you have available to you. And at this particular time, ARNIs are going to be much more expensive than generic enalapril off the shelf. So I think you have to think about your patients, and try to think about the best way to approach which medications, but it has to be in a large scale, not necessarily just always about which target receptors you want to try to attack each time.
The only other practical point I would add is the limitation of ARNI in terms of dosage formations. These are combined pill fixed dosing tablets right now. And so the dose is not necessarily applicable to the smaller, younger kids. And there we would have to stick with ACE inhibitors or ARBs rather than ARNIs.
They did make some adjustments for the Panorama trial. So there are ways to give it to the smaller kids as well. But you're right, by and large, it's still going to be more of a pill form medicine.
Yeah. There were questions about comorbidities and the impact. And I did rush through that one slide. So I'm just going to pull up one quick slide, if that's okay, to go back. And just to show what we were speaking of in terms of the comorbidities that do occur in these patients. So I'll pull up that slide really quickly. So when I was talking about in patients with genetic conditions and congenital heart disease, some of the biggest ones actually are underdiagnosed and again underappreciated in my view, especially the pulmonary abnormalities. These patients are born with abnormal pulmonary vasculature and parenchyma at the same time, and are exposed to very abnormal flow conditions throughout their lifespan. And so this is independent of their mechanical ventilation, etc., related injury. This is true pulmonary abnormalities. Renal abnormalities, both from structural and functional standpoint, are also very, very common and have huge implications in outcomes of these patients. And what we are recognizing more and more is the lymphatic abnormalities, especially in patients with complex congenital heart disease. They have very abnormal lymphatic system, which probably contributes significantly to their long-term morbidities and mortalities, as we see, whether it's plastic bronchitis or protein-losing enteropathies, etc. But even more so, just the pleural effusions, just their lung health that is abnormal, may significantly be related to the lymphatic abnormalities in this patient too. And just a quick show in terms of the impact, for example, of DiGeorge syndrome on outcomes. This is a quick study looking at postoperative outcomes for comparable conditions. And what you can see is if you have DiGeorge syndrome and have a similar heart condition as to patients without DiGeorge syndrome, everything from postoperative standpoint is significantly worse, whether it's your operative times, need for open chest, duration of mechanical support, ICU stay, overall mortality. All of these parameters are significantly worse if you have DiGeorge and have a conditions, for example, say interrupted aortic arch. And so these patients have significant comorbidities that are beyond just what we know from the congenital heart disease itself standpoint.
We have some questions that the speakers made. So I don't know if you want to show them so we can see what our audience think about it. What do you think, Shri? Is that okay?
Yeah, go ahead. Can you do that? Yeah.
Yes, sure. We have some questions from Arianna. So about imaging. So let's see, what did you understand about her talk, if you agree with her? Do you want to read, Shri? Guys, you can vote.
Yeah, I can read it. So quickly, does 3D echocardiographic ventricular volume assessment as reliable as cardiac MRI? The options are going to be no. 3D echocardiography underestimates volumes. Yes, 3D echocardiography allows for a proper ventricular volume estimation. Or 3, yes, 3D echocardiography is reliable and provide only a slight underestimation compared to MRI. We would encourage participants to answer the question.
Okay, and Arianna, can you comment on the results? I'm going to show the results now. And if you could please comment on the results.
Yes, sure. Okay, yes. Yes, it is correct. More than, yes, 50% of the audience answered properly. Yeah, the 3D echocardiography is for sure more reliable, gives more reliable measurement of left and right ventricular volumes, really close to MRI, but with a slight underestimation. So very good, because it was tricky, the second and the third. So very good.
We have one question from Aamir as well, a clinical case.
14-year-old direct cardiomyopathy optimized on ACE inhibitor and carvedilol beta blocker, but still has decreased exercise tolerance, though there is no change in edema, organomegaly, chest X-ray appearance, or echo function. Which would be the most reasonable next medication to add? Digoxin, spironolactone, Lasix, or avapritinib?
If Aamir could comment on the results, I'm going to show quickly. And this is really a very common thing that happens with us when we are patients. Yeah, it's going to be very nice to discuss that.
So I guess if, yeah. So the correct answer is B. And at least if we take our traditional approach of the stepwise approach to heart failure therapies, as we introduce ACE inhibitors, beta blockers, and an aldosterone antagonist. So I think that would be the usual correct choice, but I think it's also open to interpretation as well too, that as heart failure therapies change and maybe we become different in our way to approach this, the answer may also be dynamic in the future as well. And this may change, if you ask this question 10 years from now.
Yeah, at least from adult literature and studies, aldactone or spironolactone is probably the most underprescribed, but probably the most effective medication from the RALS study. I would encourage people to take a look at that. It's called the RALS study, RALES, which looked at the effectiveness of aldactone, and really the hospitalization rate, morbidity, mortality reduction is equivalent. So about 35% impact on standard therapies, over and above standard therapies. So the impact is equivalent to ACE inhibitors and beta blockers in terms of their effectiveness to reduce morbidities related to heart failure.
I'll try to put the link to the RALS study in the chat box, okay?
Amazing, Gil. I have one question. Can I make it? Is that okay, Shri? For all the panelists who wants to answer, how would you transition? Nida is going to talk about more the IV medications for acute congenital heart failure, and how do you transition to the chronic medication? So we have this patient with us on the ICU on Mirinon or on Epi, whatever, and then we need to transition for the long-term medication. How do you do that?
Aamir, do you want to start?
Yeah, it's a good question. So I think, you know, it's a little bit of, I'm trying to think of the best analogy is like jumping, you know, skipping rope. You got to eventually just kind of jump in and start doing it. I think you assess your patient on all the different factors of stability. And once you're kind of happy that you're not in an escalation phase, then I think it's the introduction of medicines. And at the same time, we try to do kind of, you know, go up on one and go down on the other for a general rule. You start to do a slow wean on your inodilator if it's milrinone. Hopefully your patient should be off epinephrine and things like that by that point. And also then doing the conversion of from IV to enteral diuretics as well too, if they can tolerate enteral feeds. And I think those are kind of, you know, you want to see that there's improvement in overall body state, that they can tolerate some food, that they haven't shown any signs that they're taking steps backwards. And as you introduce lower doses of ACE inhibitor and then eventually beta blocker, you are then peeling back your milrinone and other IV medicines, such that then, you know, over a period of few days, and people will do it with different degrees of comfortability as to how fast you do it. Some will do it faster than others. And I think that, you know, that's individual provider experience and comfortability. And then at some point, you're either successful, or if your patient takes steps backwards, then you know they didn't tolerate your medical therapy, and maybe that it's just a sign of underlying worsening heart failure than you anticipated.
If I can just add to what Aamir said as well, yeah, I completely agree. And I think what I find interesting is when we have patients still on, let's say, Epi, for example, but we're trying to introduce some of these oral medications, we kind of have to think about if a patient is still in a state where they're requiring epinephrine to maintain their blood pressure and output, is this really the patient that we want to transition to oral medications right away? So it's definitely prescriber and experience driven, but yeah, I agree. It's starting that kind of, like Aamir said, just jumping in. One thing that I think I would like to see a little bit more is that once we jump in, a lot of the benefit of these drugs is by reaching that target dose. So we jump in and we start, but don't necessarily titrate to the optimal tolerated dose. So I think that is one place where, as providers, we can all improve.
Yeah, and personally for me, the transition has been from inotropes. So if you're not using inopressors, so you're using something such as a milrinone, inodilator, only then the patients are ready for transition first. And then second, if you're using an inodilator like milrinone, then I would transition them to ACE inhibitors first. And only after that, think about beta blocker, because you want to be sure that the patient is not in a decompensated stage yet, or is going to relapse into decompensated stage. And so well-compensated patients transition to ACE inhibitors and then add beta blockers for optimization of therapy.
That's my view as well. I think we need to move forward, if that's okay, Shri. Okay, guys, now I'm very happy to introduce our next speaker. So we are going to have now a talk about cardiogenic shock in pediatrics. Who is going to talk to us is Renata C. Renata is now working in the University of Florida. She's from São Paulo, Brazil, from my city. And we were fellows together. So we were residents, pediatric residents together. Then we were pediatric cardiology fellows together. So I'm very happy to have her here now. She is living in the US and working for University of Florida. Thank you, Renata, for that.
Just start sharing. Oh, sorry, just a second. Share. Okie dokie, sharing now, Grace?
Yeah, all good.
Okie dokie. Yeah, we were residents and fellows together. God, has been such a long time, more than I want to say it.
Don't say it. It was
I'm
yet.
not going to. We're aging very well together, Grace. I would like to, so today I'm going just to talk about cardiogenic shock in pediatrics, and I would like to thank the Congenital Heart Academy for the opportunity. I am so honored just to be invited and to be among those smart people and all those amazing lectures that we have so far. So I don't have any financial disclosures. So cardiogenic shock is a state of circulatory failure due to impairment of myocardial contractility. In other words, it occurs when the heart and the circulation can no longer adapt to the situation. It is characterized by severely impaired myocardial contractility with increased preload, increased afterload, and persistent high heart rate. The decrease of cardiac output activates the sympathetic nervous system, releasing catecholamines. So in the early shock, there's going to be an increase of the heart rate to increase the cardiac output. But the catecholamines also increase the systemic vascular resistance due to vasoconstriction, which in long term is going to contribute for worsening the heart failure and further organ dysfunction. And unless treated, the cardiogenic shock is going to lead to multiple organ failure, which will progress rapidly to death. Unfortunately, cardiogenic shock can be a late diagnosis in patients without previous history of cardiac disease, especially in children. Cardiogenic shock is responsible for 5 to 13% of diagnosis of shock in the pediatric ER, has a mortality of 5 to 10% in hospitalized children, and has similar mortality observed in adults. It is a late diagnosis of progressed heart failure, therefore patients might have other comorbidities as sepsis, acute kidney failure, liver failure, which can lead a 5-fold increase in the mortality rate. So our objectives today are to talk about the recognition of early signs of cardiogenic shock, determine which pathway the patient is to restore adequate tissue perfusion before irreversible end organ damage and cardiac arrest occurs. Discuss about the management principles and therapeutic goals, how to monitor the hemodynamic variables and circulatory support briefly. However, the management and monitoring parameters of cardiogenic shock in pediatrics can differ between patients with normal anatomy and congenital heart disease patients. For the sake of time, I will mostly address cardiogenic shock in normal anatomy patients. I will not address the neonates or to show up in cardiogenic shock with a non-previous history of congenital heart disease in the ER. My only comment is that if you suspect a congenital heart disease in a neonate in the ER, you should start in cardiogenic shock, you should start PG, and if indicated, inotropic support and call cardiology. So the recognition of early signs of cardiogenic shock in the patient's pathways depend on which pathophysiologic state of the shock the patient is. This is a well-known chart that illustrated the pathophysiologic states of shock. If the patient's in the warm, dry state, they have normal perfusion, no congestion. Patient is still well compensated, but may have significant cardiac dysfunction. In the warm and wet, they have normal myocardial contractility, the high left ventricular filling pressures, diastolic dysfunction. Patients still have normal perfusion, but with clinical signs of venous congestion. Patients are still partially compensated, but already they can present with crackles, hepatomegaly. On this phase, patients may benefit from diuretics or inotropic support. And the cold they dry, they're going to have reduced myocardial contractility and low left ventricular filling pressures already on the systolic dysfunction. Those patients are going to present with poor perfusion, but no venous congestions. Those patients are decompensating. They're already starting appearing sick. They have increased peripheral vascular resistance and may have oliguria and altered mental status. And in the cold wet, they're going to have reduced myocardial contractility with increased filling pressures, with systolic and diastolic dysfunction. They have poor perfusion with venous congestions, are the sickest group of all. Those patients usually already require inotropic support and may require mechanical support. With all those clinical symptoms, ancillary tests will guide for evaluation management. The chest X-ray can show the cardiomegaly, signs of pulmonary venous congestion, signs of previous cardiac surgeries like this one if the patient and family are not able to provide this information. The electrocardiogram is going to give us values information regarding the type of rhythm, is patient on sinus or having tachyarrhythmias, SVT, VTAC, PVCs, and the PVCs ST elevation Q waves, it helps not only the diagnosis, but on possible treatable causes. This AKG on the left is starting already showing the ST elevation that we saw in one of our patients with Kawasaki that had a thrombus in the aneurysmatic coronary artery. And this AKG on the right shows in a patient dilated cardiomyopathy with severe heart failure and PVCs. The echocardiogram is another variable tool for diagnosis and congenital heart disease, determine the cardiac function, effusion among FL. Those video echoes, they show the dilated cardiomyopathy with severe decreased systolic function. Here on those echo images, here on the left, shows a patient that came for evaluation with severe heart failure, and the echo showed the atresia of the left osteocoronary artery when we see those flow that when we suspected central cath. And this patient improved after surgical repair. And this echo is showing the aneurysmatic dilated coronary artery that we saw on the Kawasaki disease patient. In patients at risk for or in a state of shock, the therapy is directed by optimizing the systemic delivery of oxygen, manipulating the hematocrit, oxygenation, and cardiac output. Therefore, the goal of treatment is to restore adequate oxygen delivery through optimization of ventilation and gas exchange, optimization of preload and afterload, and treatable and curable causes. Among the strategies to improve the relationship between the delivered oxygen and oxygen demand are minimizing the aerobic metabolism by eliminating respiratory work with mechanical ventilation, providing sedation, reducing consciousness, muscle relaxation, and avoidance of hyperthermia. Therefore, the optimization of ventilation work to decrease the cardiac load and decrease oxygen consumption. In addition, the positive pressure also decreases the ventricular afterload, and the mechanical ventilation also promotes airway stabilization in patients that have ultramental status. The hemodynamic monitorization is going to include continuous telemetry, blood pressure that can be invasive or not, and the blood pressure indicating if the patient can be hypovolemic, has pulse paradoxes as in tamponade, patient present elevated high blood pressure in the upper extremities, which can indicate an obstruction. Central venous pressure is an indicator of volume status. And when increased, it can indicate intravascular volume overload or cardiac tamponade. When it's low, it's indication of low intravascular volume status, is inadequate preload, and urine output are among the few measurements that evaluates the preload, afterload status, and indicates the need of volume expansion, diuretics, and inotropic support. Other monitorization which helps with determination of treatment are the oxygenation that we check by pulse ox, and the tidal CO2, and labs, which we're going to evaluate the progression, possible etiologies again, treatable causes as electrolyte imbalance, coagulopathies, and evaluate for organ dysfunction. Among the labs, the SVO2, which can be measuring the SVC on the pulmonary artery if there are no shunts, it can be an indication of the cardiac output. If it's low, it's a low cardiac output, or it can be a sign of increased O2 consumption and see an increased metabolic states as fever, signs of hypoxemia, anemia, or can be, unfortunately, like just a mechanical catheter position. However, if the SVO2 is increased, it can be a sign of decreased O2 extraction or decreased dissolved O2 content. It can be a left to right shunt, or again, a catheter position. Among the other labs, lactate is an important marker for cellular damage and aerobic metabolism, and is an indicator of worse prognosis when it's elevated in the first 24 hours. The measure of pulmonary artery pressures is still not very common in pediatrics in comparison with the adults, but it has been done more frequently recently. If you have an elevated pulmonary pressures, it can be indicated not only for mechanical obstruction of pulmonary circulation, as we see in thromboembolism of pulmonary artery, but signs of lung diseases can have atelectasis, pleural effusion, or indication of increased left atrial pressures due to worsening LV dysfunction, or increased mitral regurgitation. And a decrease of the pulmonary artery pressures can be a sign of hypovolemia, low cardiac output, or severe obstruction in the pulmonary flow. So vasoactive drugs should be chosen based on the desired cardiac and peripheral vascular effects and the organ function. Keep in mind that their effects on the cardiovascular receptors are dose-dependent. And you might want different effects depending on which pathophysiology state of shock the patient is. Ideally, we'll choose therapies that is going to reduce the ventricular afterload to increase the ventricular ejection. They are vasoactive agents that dilate the arterial resistant vessels, decrease the vascular impedance, increase stroke volume and cardiac output, but have no significant effect on the ventricular filling pressures. However, if you combine a venous arterial dilators, they can significantly reduce the ventricular diastolic volume and pressure by reducing the systemic venous return to increase stroke volume and cardiac output. However, the inotropic stimulation, in addition to the patients already being tachycardic, can also increase the myocardial O2 consumption and increase the chance for tachyarrhythmias. And despite an elevated heart rate being needed to maintain the cardiac output when stroke volume is limited, a failing myocardium has also been shown to have an inverse force-frequency relationship, meaning an increase in the heart rate can actually lower the stroke volume and cardiac output. In addition, tachycardia can compromise ventricular filling and coronary perfusion, contributing to decrease the stroke volume and cardiac output. And this table is just describe a few inotropes medication commonly used in cardiogenic shock, their effects and which receptors. I know that Nida is going to talk much more about that in the next lecture. So, in patients with refractory cardiogenic shock, mechanical circulatory support is recommended. ECMO has a few advantages, can be placed in the emergency setting, sometimes at the bedside, and is also indicated when the patient has pulmonary disease combined. VADs usually are placed for longer needs, and those patients usually can go for outpatient settings. ECMO, most places as a bridge almost for decision. The ECMO and the VADs are options as a bridge for heart transplant in pediatric population. And the mechanical support come with their own risks and benefits will be discussed in the next lectures. And the placement of mechanical support is based on the clinical, laboratory, and prognosis criteria that is considered jointly by Peds cardiology, the intensive care team, and the surgical team. And just briefly, regarding ECMO, according to, this is the data from the Extracorporeal Life Support Organization that show that ECMO has a pediatric survival of 50 to 6% for extracorporeal life support, but when placed on CPR, the survival is only 43%. So, and I think that is a quote from C.S. Lewis that illustrates well the points of cardiogenic shock, because cardiogenic shock is not the most common type of shock, but once recognized, we'll adjust the treatment toward this entity and hopefully we can improve those outcomes. Thank you.
Thank you, Renata. It was very good. Thank you very, very much. And now we are going to move forward to a very interesting topic. We are going to talk about a pharmacology of the acute heart failure. So we are going to have the clinical pharmacist of my unit. Today, a lot of nice people from that I know. I'm very happy for that. I'm very happy to introduce Nida Siddiqui. So she is a clinical pharmacist, a specialist for pediatric critical care and transplantation at Sidra Medicine in Doha. Originally from the US, she earned her doctor on pharmacy degree from University of Buffalo School of Pharmacy in New York and completed her postgraduate residency and training in pediatrics and transplantation in New York as well. Prior to join Sidra, she worked in Montefiore Medical Center for 6 years as the clinical pharmacist, specialist in heart failure, mechanical circulatory support, and cardiac transplantation for adults and peds. Thank you, Nida. We are very happy to have you here.
Thank you so much, Grace, for having me, and to the entire Congenital Heart Academy. Let's see if we can share screen. Okay. Okay. So today I'll be talking, as we mentioned, some of the pharmacotherapeutic strategies. So I hope this presentation will kind of pick up on a lot of things that Dr. Shri, Aamir, as well as all the other speakers have mentioned before me. Okay, so before we start talking about acute decompensated heart failure, just we all need to be on the same page of the definition. So as mentioned a little bit in the presentation right before me, we'll be focusing in this sense on the continuous infusion of vasoactive agents and diuretic agents in patients that are presenting with either systolic or diastolic cardiac dysfunction. Unfortunately, CICU admissions are the final shared pathway for pediatric patients with heart failure, as we all know, with actually one of the most common reasons for CICU admission being the treatment and prevention of low cardiac output syndrome in our post-cardiac patients. They carry a higher ICU mortality rate when compared to our adult counterpart patients, with the highest rate in our congenital heart disease population. It's resource intensive on the system, as mentioned in other presentations as well. And finally, again, a common theme, there's a lack of pediatric focused published guidelines that are, let me see. Sorry, Grace, are you able to see me? It's okay?
Yes.
Yes.
Sorry.
Okay. So yeah, so there's a lack of pediatric focused guidelines and clinical trials, which force us to not only extrapolate from the adult data, but also the pediatric registries out there, which, you know, I have to commend my colleagues for actually putting those together because they do offer quite a wealth of data to us. And finally, from our clinical experience. And so these are all the reasons why we need to kind of talk about how to maximize their therapies. So when we talk about the epidemiology of pediatric heart failure, as we have talked about in other presentations, we have congenital heart disease and acquired heart disease. And I kind of pulled out cardiac transplant patients that are readmitted and added them as number 3 because they are essentially treated as rejection until proven otherwise. So yes, they may be treated as acute decompensated heart failure, but there's another entire portion that goes into their therapy, which will be modulation of their immunosuppression. And so without the risk of oversimplifying, I know our surgical colleagues will speak right after me. So essentially, we can talk about the presentation of heart failure or treatment selection as mechanical, so to speak, or neurohormonal, where mechanical might be just straight surgical intervention. So for this discussion, we'll be talking more about the neurohormonal. So again, ISHLT has also adopted this as the categories for acute decompensated heart failure. And so, you know, essentially we're talking about volume versus pressure, or preload versus afterload as our 2 primary drivers. So if we take some of our decompensated states and take a look at them, the wet and warm, these are the patients that will present with increased filling pressures, but have adequate perfusion. So we may actually just get away with diuresis in these patients, but you know, some may require the addition of an afterload reduction agent. Our cold and wet, which is the cardiogenic shock patients, they have increased filling pressures and also poor perfusion. So these are the patients where they'll really need some afterload reduction in addition to diuresis. And if their blood pressure cannot tolerate that, we may actually have to support them with inotropes. The cold and dry patients, so this is kind of our rarest, but also worst case scenario for patient presentation. And this is when they're coming in with low filling pressures and poor perfusion. And so usually our goal with them, or initial step, will be providing inotropy and fluids. And these are usually the patients that go on to mechanical circulatory support. And so what is the ideal agent when we talk about acute decompensated heart failure? Well, that agent would most ideally reduce symptoms, of course, optimize hemodynamics, both systolic and diastolic function, and do that without increasing myocardial oxygen demand. It would be an agent that elicits minimal to no impact on the intramyocyte calcium concentrations. And if we're making a list and Santa Renata, if you're listening, we also want a drug that has no adverse effects, of course, minimal chance of developing resistance or tolerance, a drug that shows decreased mortality and added survival benefit, a drug that will decrease our hospital length of stay, because we know that translates to money spent by the system, and also increase our patients' quality of life. So quite the hefty list. So I'm not going to go through every drug here. You know, these tables will be available if you want to refer to them later, but let's talk about volume overload first. So as previously mentioned, loop diuretics are a mainstay of therapy, and usually the first line agent that we go to because they provide the most potent, if you will, diuresis. The one thing I just want to focus on here from an acute decompensated standpoint is the idea of infusion versus bolus. So there's plenty of data out there now showing the benefits of administering your loop diuretic as an infusion in these patients versus the bolus for reasons of better diuresis, decreased chance of resistance, as well as minimization of adverse effects, especially in our younger patients. And that idea comes from this idea of spending the most time above your natriuretic threshold, which you will achieve with the infusion dosing versus the bolus dosing. So after the bolus, with the bolus dosing, after the high concentrations wear off, there's this feedback, if you will, of vasopressin release and sodium that follows. So, you know, just something to keep in mind when you have a patient there in an acute decompensated state. I also want to just mention that thiazide or thiazide-like diuretics in the decompensated state are usually added on as an adjunct. You can add them on short term to overcome the resistance, any resistance to loop diuretics, or just to, you know, optimize your diuresis. And many centers now also use combined Lasix diuryl or furosemide chlorothiazide infusion and actually run them together. But it is a bit costly due to the cost attached with IV chlorothiazide. And finally, vasopressin receptor antagonists. So there's not a lot of data out there right now in pediatrics, but it has been reported with some success in case reports primarily. But just to keep in mind that this would be, of course, contraindicated in your hypovolemic patients. And of course, last resort would be dialysis with the goal of reducing preload. So let's switch over to vasopressors and our inotropes. So what are we doing around the world? I pulled some data from some of the major registries just to share with you all. And this data is supplemental or data on vasoactive medications administered during heart failure admissions. And so as you can see, for most centers in North America, they're using milrinone, with the bulk of the milrinone being used more in the non-congenital patients compared to the congenital population. And this was found to be statistically significant. And usually the second agent being added on is epinephrine. I also just want to highlight that calcium gluconate or calcium infusions are also being commonly used more so in the congenital heart disease patients when compared to the non-congenitals. And last but not least, the addition of vasopressin as well, same strategy, more for the congenitals compared to the non-congenitals. Okay, this was pulled from a registry coming to us from Italy. And so this one focused primarily on drug of choice for management of low cardiac output syndrome, which is, you know, the other one included all patients, but I do think that's still important to mention. So the drug of choice for patients with initial treatment for low cardiac output syndrome with elevated SVR, the drug of choice, of course, was milrinone. Second was dopamine. The drug of choice for LCOS with low SVR, the first was epinephrine. And for patients as expected with LCOS with high PVR, the choice there was also milrinone. And finally, this is pulled from a European registry of 30 or so European countries, also focusing on the treatment algorithms for low cardiac output syndrome, which is, as we mentioned, one of the most common presentations. So here again, milrinone takes the win for patients with LCOS and elevated SVR, with low SVR actually being dopamine in European countries, and for elevated PVR, again, milrinone. I show you all these just to kind of present, some of the variations throughout the world in international practice, and also actually some of the similarities that we'll see. So now let's talk about these drugs just a little bit. So the pressure overload is essentially what we try to address here with these sympathomimetics or catecholamines. And again, I won't go through the entire table, but I just want to point out a few things that dopamine, even though it's fairly still commonly used, it is actually a precursor to norepinephrine. So dopamine will be converted to norepinephrine and elicit its effects. And vasopressin, even that we are caring for mixed populations, but what studies have found that vasopressin is actually endogenously low in patients after cardiopulmonary bypass or, cardiac surgery, but high in patients, children that are presenting with chronic heart failure. So when we talk about drug selections and which patients might benefit from vasopressin or experience detrimental effects from vasopressin, we just need to keep that in mind. So if we can just look at this very simplified version of what's going on in the myocardium. So all the drugs that we are utilizing that target our alpha and beta adrenergic receptors, such as epi, dopamine, dobutamine, norepi, and milrinone, are essentially working in two primary ways. They're increasing your CAMP and effectively increasing your intracellular calcium. With the exception of milrinone and perhaps calcium, all of these will increase your myocardial consumption as well. So, and of course, you get the outcome of increased cardiac output, but what are the limitations of these therapies? Well, first off, there's downregulation of the adrenergic receptors in chronic heart failure patients. So you're already starting at a loss, if you will, in terms of the effectiveness that these drugs can perhaps achieve in our chronic patients. As I mentioned, there's an increase in myocardial oxygen consumption, which, if it continues, it can cause further damage to the myocardium. And as we escalate the doses to achieve what the output we're looking for, there's an added effect of chronotropy. And finally, we won't even have time today to discuss the RAS activation of the renin-angiotensin system that occurs with the production and escalation of catecholamines. And I guess what I'm trying to say here is that the impact of vasoactive drugs on the mortality and long-term survival of our heart failure patients still remains very unclear, even though we use it very frequently. So if we talk about pressure afterload from the vasodilators or from reduction of afterload standpoint, we have three main drugs that are being used most commonly: milrinone, nitroprusside, and nitroglycerin, with a mix, as we can see from the registries. And as a pharmacist, I couldn't help myself. I just have to point out that nipride should be used, nitroprusside, with caution because of the risk of cyanide toxicity, and I have listed some of the risk factors and presentations for you there. So let's talk about milrinone, the inodilator. So, milrinone's kind of the superhero of the inopressors or inodilators, the vasoactive agents. It's the drug that we've all come to really rely on for not only low cardiac output syndrome prevention and treatment, but also primarily for that cold and wet presentation. And so is it really a good drug? Well, there's no increase in myocardial consumption, so that's great. It provides both vasodilation and inotropy, so afterload reduction and the inotropic effect. So that's also great. But is there a survival benefit? So when we look at the LCOS patient population, we do actually see the primary trials showing a dose-dependent decrease in the incidence of post-operative LCOS. However, if you look at the adult data from milrinone, we see some concerning effects of potential adverse cardiovascular outcomes, particularly in the ischemic heart failure population. Now, the relevance to this in terms of the heterogeneity of heart failure with which children present may not be very relevant or completely relevant, but it's still important to keep in mind these findings. And really, is it a one-size-fits-all? Should all patients receive milrinone, and will they all respond? So there are quite a few animal studies showing that, particularly in neonates, stimulation of the CAM pathway and phosphodiesterase inhibition actually has less effect on contractility when compared to adults. And this was attributed primarily to developmental changes in phosphodiesterase enzymes that occur with age. And there are some showing better contractility response when combined with beta agonists versus milrinone alone. So let's talk about levosimendan. I saw in the question and answer box a lot as well. What about levosimendan? So is it going to be our new hero like milrinone, or is it really just another kid on the block? Well, it's been out since 2000, and considering it's been 20 years, there's not as much talk on it as I would expect. It's actually still not approved in the United States, so it's available in 60 countries, Europe and beyond. And so the claim to fame here is increased calcium sensitivity of troponin C, and thereby creating its effects that are independent of adrenergic receptor activity and independent of CAMP, with no myocardial oxygen consumption. So it does tick some of the boxes that we were talking about with the most ideal drug. And you would expect to see increased contractility, increased lusitropy, vasodilation, as well as a reduction in SVR. Another benefit of levosimendan is that the recommended dosing schedule is really only for 24 hours. So what does the data show? Well, there were plenty of, I shouldn't say plenty, there were a few major trials done in the adult data that led to us feeling good about, moving this forward in pediatrics. And essentially what we found in the pediatric data, I took the top 4 trials and I picked these based on ones that were more prospective, double-blinded or randomized, or had a decent patient population. And when you review all the levosimendan data out there in pediatrics, you can really divide it into patients that are receiving it for low cardiac output syndrome prophylaxis post-op, or truly end-stage heart failure patients that are inotrope dependent. So if you look at the first 2 studies, they were for low cardiac output syndrome prophylaxis. And essentially, the majority of these studies find no additional benefit of levosimendan in really improving either ICU stay, inotropic score, mortality, so on and so forth, even actually duration of mechanical ventilation. However, when we look at patients that receive levosimendan that are end-stage inotrope dependent, we find that there is a statistically significant reduction in their inotrope requirements and needs while being on levosimendan. And the duration of receiving levosimendan was 24 hours in all these, except for one which kept it on for 48 hours. So it really gets me to think that is the potential of levosimendan really in the acutely failing heart and not necessarily for prevention. So, its role in everyday therapy is still, the jury is still out. And finally, I'll just mention nasiratide, which was actually pulled from the markets, at least in the US, in 2018. So it was meant to be a recombinant human B-type natriuretic peptide. And essentially, due to no impact on survival, heart failure symptoms, decreasing hospitalizations, and this concern for increasing risk of renal dysfunction and possible increase in 30-day mortality, the use has significantly decreased. So what are the future directions for decompensated heart failure therapy? Well, to be honest, not much has changed in the last 2 decades, I would say, with the newest drugs being nasiratide and levosimendan. However, even though it's been about, approximately 20 years, they still lack the current or lack the relevant clinical trials that are needed in the pediatric patient population. There are a few other agents that have been studied in adults for acute decompensated heart failure. I've listed their mechanism and the primary trial that led to their approval. However, once again, there are no trials yet that have come out to study this in the pediatric patient population. And essentially, if you look, for example, the serelaxin, really what we're finding is some improvement, but really no benefit compared to placebo. So what I'm saying is nothing too earth-shattering or groundbreaking for us. And so the question is then, what should we explore? Renin inhibitors in acute decompensated state, the role of calcineurin, since they actually modulate calcium as well, and whether or not we need to shift our focus to long-term survival, or perhaps, as other speakers have mentioned before me, looking outside the myocardium. And so that brings me to one of my favorite topics, pharmacogenomics and personalized medicine. So the question we want to answer here is that, can we use genetics to predict who will or won't respond to the current treatments that we already have? Or are these perhaps new therapeutic targets that should be explored? And the other question to address is, can we explain the significant intra-patient variability we see in the pharmacokinetics and dynamics of these therapies? So I won't go through all of it, but I've highlighted 4 areas which I think are relevant to the acute decompensated heart failure state, in which there have been genetic polymorphisms identified. So for the sympathetic nervous system, the natriuretic peptide system, the RAS system, and of course our gut microbiome, which is gaining more and more interest as the years go on. And what about our congenital patients? So this was already mentioned, I believe, by Dr. Shri. And so, the question here is, if we understood our congenital heart disease patients' genotypic diagnosis clearly, could we then predict the phenotypic response, and would that help us in our management? So hopefully in the next few years, we'll see some more track on this. And lastly, I just want to close by mentioning the multidisciplinary approach to heart failure management, being cognizant that perhaps most of our audience today are physicians and surgeons and residents in training. So, we all know now that the gold standard is a multidisciplinary approach, which has shown significant reduction in mortality, hospitalizations, and healthcare costs. And so just a few ways that you can perhaps collaborate with your institution's clinical pharmacist, or if you don't already have one, ask for one, because as Grace will probably tell you, it's very hard to shut me up on rounds because I have a lot to say about ways to optimize our patients' dosage forms, preventing errors, drug interactions, and then some of the bigger issues that come up once the patient's leaving the ICU, transitions of care, coming up with a good discharge plan that maximizes the patient's compliance. For example, the last patient that I transitioned out was scheduled for oral heart failure medication 6 times a day. Well, I can tell you that no patient, I don't even think you and I would take that. So, it's important to make it realistic. And finally, using them for pharmacoeconomic vigilance, educational resources, and one of my areas of interest, research and publication. And so in conclusion, there isn't really a lot that has changed in way of drug approval for acute decompensated heart failure. We've seen a lot of gain perhaps in the chronic heart failure maintenance role, as Dr. Aamir had mentioned. But are we looking in the wrong place? Is there a role for therapy outside the myocardium, or role for developing on pharmacogenomics? And focusing more on pediatric specific trials and the long-term impact of these vasoactive drugs. And with that, I will say thank you from Doha, Qatar.
Thank you, Nida. Thanks a lot. I know it cannot be so easy to work with Grace, but I'm sure you're improving a lot.
It's an absolute pleasure, like you wouldn't believe. It really is.
But I can tell you that in Italy, we don't. In Europe, I say pharmacist is not the one person that you are presenting us. It's a completely different position.
Yes.
But I'm sure this type of message will reach mostly of the Italian or the European center, and think in different ways every time.
Yes, absolutely.
Thank you very much.
Thank
so
you.
Now it's time to come back in Italy, and it's a big pleasure for me to introduce Nino Amodeo, Dr. Amodeo, and thanks to Shri that give me the opportunity to do this, because Nino Amodeo is, first of all, is a friend, is a very important pioneer in Europe about congenital heart disease, and is an extraordinary clinical investigator. And he has a lot of experience in congenital heart disease, heart transplantation, left ventricular assist device, and total artificial heart. And in 2015, implanted for the first time in Italy the infant Jarvik 2000 in a very small child. And he started a very special program as a destination therapy for a patient with Duchenne cardiomyopathy. I think that Bambino Gesù Hospital with Nino has built a fantastic, real group of work, and very serious people. Mostly of the paper was presented today was realized by anesthesiologists and surgeons and colleagues from Bambino Gesù, and it's a real privilege for us to have this center in Italy. Actually, Nino is the surgical director of mechanical circulatory program at Bambino Gesù, and at the same time he has a lot of contribution, mostly in single ventricle physiology, about venous unifocalization. I think that when you do this job, you need vision, and you need to have a dream, and I'm sure that Nino has both together with a very big passion and science approach. Thank you, Nino, and it's our pleasure to have you with us.
Thank you very much, Sasha, for your very nice words. I'd like to thank you and Shri for the kind invitation. And my talk is on surgical treatment of acute and chronic heart failure. As you can imagine, it will be taken hours to talk about all these fields, but I will try to be focused on the hot topic on the field. And a disclosure, just to have an idea, this is the fourth annual pediatric registry for Pediatrics. And as you can see, just to have an idea, how is the increase of VADs in the last years, now reaching more than 1,000 in North America. This gives you the feeling that how is moving our field in pediatrics. Now let's go ahead with the acute heart failure. As you can imagine, we can have an acute heart failure in congenital heart disease, myocarditis, dilated cardiomyopathy, and of course in rejection in heart transplantation. And which one are the mode of support? It can be in acute paracorporeal continuous flow pump, Impella, Protect Duo on the right side, and ECMO. I will not talk about ECMO. I will be concentrated on other forms of mechanical circulatory support. From the Pediatrics as well, as you can see here, you can see that the red lines, you can see here the paracorporeal continuous flow, and as you can see here, this one is the type of support that has got the worst survival compared to the implantable continuous that still have a 90% of survival at 1 year. But despite this, the paracorporeal continuous flow, despite low survival rate, have highest rate of recovery. And if you look on the patient profile, you still have that the patient in critical cardiogenic shock has got the worst survival compared to the other patient profile. Well, few words on the Impella. The Impella has been widely used even in pediatrics. And if you look at the multi-center study of the Impella device for MCS in pediatric and adolescent patients, you can see that in this case there is a 32% of patients died. It of course reflects the high critical patients that usually has been supported with Impella in pediatrics, and of course all these patients usually are extremely sick patients with multi-organ failure. Just to have an idea how to support a patient, a pediatric patient that come to the hospital with the acute cardiac failure. This is a case that we have had in hospital in the last months. 14 years old, 48 kilograms, BSA 1.5, fulminant myocarditis H1N1. You have to consider that the myocarditis from influenza virus is probably the worst myocarditis that you can have, with high mortality in all series. The patient come with a critical cardiogenic shock and severe biventricular dysfunction. What you should do, and what we have done, is Impella on the left side and the Protect Duo for the right ventricle on the right side. And we can support the patient on the right side, on the left side, just to bridge the patient to the decision. Unfortunately, the left ventricle didn't show any form of recovery, so we have to go to the HeartMate reimplantation, but the right ventricle was still supported by Protect Duo cannula. And this is an interesting case because we keep the Protect cannula inside during the operation of HeartMate reimplantation. Then there was a satisfactory recovery of right ventricle, allowing removal of the Protect Duo cannula after 40 days of support. And of course, if you look, the problem is that this patient, when you need to have support in the postoperative period, it means that the right ventricle probably is going to suffer in the near future. So we removed the Protect Duo cannula, but there was a recurrence of a chronic severe right ventricular failure with ascites, slow flow at VAD, poor feeding. And this is probably the worst question that we can have in this situation. How to assist right ventricle on the long term when you already have a LVAD inside? We didn't know the answer because there are no data in pediatrics. There are data on adults with a group of Prague with very good results of BiVAD. But anyway, intracorporeal BiVAD still have 50% of mortalities at 6 months on adult side. So the question was hardware plus HeartMate, belly heart plus HeartMate, 2 HeartMate. We really don't know which one was the best answer. And this is extremely important because if you look at the literature, when you have the use of inotrope of any sort of RVAD in the immediately postoperative period, these ones are the ones that has got the worst survival. You can see here, you have a 50% survival at 2 years. So back to the question, what to do in this case? What we did is to implant another HeartMate 3 as RVAD. And now 5 months after BiVAD implantation, Punda is still waiting for cardiac transplantation. We had a major complication, a cardiogenic shock due to hemothorax for a rupture of mammary artery, and we had to go in OR and fix the rupture of the internal mammary artery. Then let's go to the chronic heart failure. Of course, even in chronic heart failure, we have congenital heart disease, dilated cardiomyopathy, rejection, and destination therapy. Which one are the mode of support in chronic heart failure? Of course, we know implantable, continuous VAD. You can use HeartMate 3, hardware. In Europe, we have JAV 2000. And then, of course, belly heart in small children, paracorporeal pulsatile flow pump, and a few words on the infant Jarvik. If you look at the VAD survival stratified for primary diagnosis, you still have that the survival for cardiomyopathy have a better survival compared to congenital heart disease. And if you look at the comparison between implantable and paracorporeal, you can see there is still a striking difference. But if you look the VAD for congenital heart disease versus non-congenital heart disease, it's interesting to see that for paracorporeal pulsatile devices, you can see that the patient with congenital heart disease has the worst prognosis. And of course, even worse, patient with paracorporeal continuous devices in congenital heart disease. But interesting, for implantable continuous devices, there is no difference between congenital heart disease and non-congenital heart disease. So let's go and talk about congenital heart disease. Of course, this is a pioneer paper made by the group of Dr. Morales, who was the first to use a support in Fontan circulation. And of course, this paper opened up a wide windows on the support patient with congenital heart disease. But what I think is that probably the most clever idea came by Dr. Adaki from Texas Children's Hospital. Now, with more and more patients surviving vascular cell syndrome, we have more and more patients with a gland not suitable for Fontan operation that requires cardiac transplantation. And this is, I think, probably a very interesting solution for this patient with dysfunction of the single ventricle to commute the gland to Fontan and assist the patient with an LVAD. Then, of course, we have dilated cardiomyopathy, but probably the most important thing is one size fits all, and this is the question that we have to do. This is probably the smallest patient with VADs done a few years ago at Freeman Children's Hospital. It was an actual in a very small child. And pushing the limits, this is the paper from Caravana, in which a patient of 4 years old, 14 kilograms by, and you can see here a double hardware intrathoracic positioning. This is one of our patients with hypertrophic cardiomyopathy with the small left ventricular cavity. We had to remove a lot of muscle inside the left ventricle to have a good cavity to insert the pump and to keep the pump working nicely. But the question is, one size fits really all? Well, what really we believe that it's extremely important to have advanced imaging and virtual surgery for this patient. Because with advanced imaging, you know which kind of VAD you can insert and where you have to insert the VAD, especially for LVAD and for total artificial heart, and especially in special condition. This is one patient with left diaphragmatic hernia, dilated cardiomyopathy, severe scoliosis. He had 10 years old, 18 kilograms. With the use of advanced imaging, we decided to insert the hardware, and this is 1 year later on VAD, still on VAD, waiting cardiac transplantation, and he gained 10 kilograms, now is 28 kilograms. So the use of advanced imaging is incredibly important. Then a few words on destination therapy. We started the program of destination therapy a few years ago, and we have been using Jarvik 2000 with retroauricular pedestal, and we have the longer DMD patient support was 6 years. With that, we have been able to prolong the life of this patient that otherwise does not have any other option. Sometimes this is a destination VAD for Philip Fontan. This is a case from Texas Children's Hospital, 11 years old, with a CCTGA, with a single stage Fontan. He is on support, but is not eligible for transplant due to obesity. It is another example of destination VAD in the congenital heart disease. And then a few words on Berlin heart. The 1 year survival of Berlin heart is about 73% based on the worldwide registry from Berlin heart. But you can see there is still difference between LVAD and BIVAD in terms of 1 year survival, with a worse survival in BIVAD compared to LVAD. And if you look for diagnosis, the survival is much better for dilated cardiomyopathy compared to congenital heart disease and the resective cardiomyopathy. Myocarditis still have a good survival compared to congenital heart disease. And if you look the winning details per diagnosis, you can see that myocarditis still have almost 20% of winning, but the dilated cardiomyopathy still have less than 3% of winning. And this is the same situation that we have in the registry of Perimax, where if you compare the implantable continuous, the percentage of winning is less than 2%. The use of Belinar in children less than 10 kilograms is a very tough condition. Of course, experienced centers have a good results in this specific condition. And if you look the paper from Oliver Mira, you can see then the era after 2012 get better results, and the survival improved in all children less than 10 kilograms, and only inferior in children than less than 5 kilograms compared to the largest patients. So the risk factor are only the weight less than 5 kilograms and patients with congenital heart disease. No way that the use of bivalvuline start a new era for belly heart. We have to thank Christina van der Ploem from Boston Children's Hospital, in which first started the use of bivalvuline in belly heart patients, with the reduction in major bleeding and stroke. And we have the same experience in Europe. We first started bivalvuline in belly heart in Italy, and we have very good results. Even the patients from the people from Canada has got the same good results with use of bivalvuline. And a few words now on the infant Jarvik. Of course, we don't know anything now about the infant Jarvik. Probably the COVID has stopped everything. We don't know which one will be the future, but anyway, this is a pump that can have a role in the very small patients. We first did the implantation of infant child in a very small patient, and this is our experience. 3 patients, 2 with dilated cardiomyopathy, 1 congenital heart disease, all 3 less than 10 kilograms, and the mean time of support was 11 months. All 3 patients recovered, and the VAD was explanted in all 3 patients. And this is the patient that was discharged after 189 days of support on infant Jarvik. In conclusion, although considerable progress has been made with the ventricular assist device for adults, security support in children is rapidly growing, and the near future is promising. Thank you very much for your support.
Thank you so much, Dr. Amedeo. That's fantastic. And again, the surgical applications and the room for technology development, specifically in pediatrics, really has to be led from the pediatric community, as we've learned again and again. So thank you for your insights. Really, we're ending the session on a very high note. It gives me a personal pleasure, joy, and it's a privilege to introduce Dr. Javed Butler, who will be speaking to us about heart failure today, learning from the adult colleagues. Dr. Butler is the Patrick Lehan Endowed Chair in Cardiovascular Research and Professor and Chairman of the Department of Medicine at University of Mississippi in Jackson, Mississippi. And prior to this, he served as the Charles Gargano Professor and Director of the Division of Cardiovascular Medicine and Co-Director of the Heart Institute at Stony Brook University in New York. And he served in various leadership positions for heart failure and transplant, both at Emory University and at Vanderbilt University. He received his medical degree from Aga Khan University and completed training at Yale before moving on to Vanderbilt. Dr. Butler is really a force in adult heart failure and is well known, well recognized for his role in both research and clinical medicine in adult heart failure. His research focuses on such clinical trials in in patients with heart failure. Wish it was pediatric. He serves on national committees for ACC, for AHA, American Heart Association, National Institute of Health, NIH here, US Food and Drug Administration, Heart Failure Society. Very importantly and uniquely, he's the recipient of Simon Dack Award by American College of Cardiology, as well as the Time, Feeling, and Focus Award by American Heart Association. There aren't many people who are both recognized by ACC and AHA for various reasons. We won't get into that, but Dr. Butler has that unique recognition from all of the societies within the US. He has authored more than 700 peer-reviewed publications and has been contributory to very important guidelines coming out of AHA for adult heart failure. So again, it's a joy and a privilege to welcome Dr. Javed Butler for the talk today. Thank you.
Shri, thank you very much. That was an overly kind introduction. So the task given to me is to just bring you up to date where adult colleagues are thinking about heart failure. I will have to apologize about one thing, that in 16 minutes, I'm giving cardiology rundown. So my apologies that I will be going a little bit fast today because we're running a little bit over time. These are my disclosures. I am a consultant to pretty much all the trials that I will be discussing today, so please keep that in mind. Again, the field of heart failure in the adult is absolutely exploding. There is so many trials that are coming out that in the interest of time, I will not talk with heart failure with preserved ejection fraction, which I would think is not a focus in pediatrics. I will not talk about comorbidities because there's a lot going on for management of comorbidities as a management option for heart failure, which again, I would assume is not a very relevant topic for pediatrics. I will not talk about devices, either acute or chronic, again, in the interest of time. And I will primarily focus my comments on medical treatment and update for heart failure with reduced ejection fraction. So these were the guidelines that came out in 2013. Life used to be simple, basically said that use ACE inhibitor, beta blockers, and MRA on all heart failure patients who don't have any contraindication. So that was simple enough. Triple therapy with ACE inhibitor, beta blockers, and mineralocorticoid receptor antagonist. Obviously, there are a whole lot of sort of nuances under that umbrella, but by and large, it was a reasonably simple calculation. So then life started moving forward. So we had several trials with other neurohormonal blockade drugs that did not improve outcomes. Again, in the interest of time, I won't go over the data, but the bottom line is that just piling on one after another, neurohormones was not working out. Endothelin blockers, vasopressin antagonists did not improve outcomes, whether it is that the fourth, fifth, sixth neurohormonal blocker is not needed, whether it is we tested the wrong population. We can argue about that, but the bottom line is that that strategy after angiotensin 2, aldosterone, and norepinephrine modulation, adding more neurohormonal antagonists was not working out. So we had to start sort of thinking a little bit differently. So one of the things was that in order to counteract these bad neurohormones that go up, Mother Nature has good neurohormones that they go up, these vasoactive peptides like ANP, BNP, CNP, adrenomodulin, and the mindset shifted from just down-regulating the bad neurohormone to up-regulating the good neurohormones and trying to sort of bring a balance between the two. So there were many comments made in earlier presentations about valsartan, sacubitril, or ARNI. So that was the whole concept, that along with regulating the bad neurohormones, can you upregulate good neurohormones and try to bring the balance? So that was tested in this trial called Paradigm HF, was the largest trial ever done in heart failure with reduced ejection fraction. And this was sort of a bulletproof trial, no matter how you slice and dice the data. It was positive. Remember that there is no placebo control arm here. This is high dose enalapril. So this is as compared to the standard of care. There was a 20% reduction in cardiovascular death, 20% reduction in heart failure hospitalization. Obviously, combined endpoint was improved. And another trial called Pioneer HF, which was done in the in-hospital setting. So same sort of intervention, enalapril versus valsartan sacubitril, but now it started in the hospital setting in people who are not sort of crash and burn in the hospital for about 24 hours. Then you can see even in 8 weeks, there was a greater than 40% reduction in recurrent readmissions. And then a single arm study showing substantial reverse remodeling and improvement in ejection fraction as well. The other trial that came out since that guideline in 2013, other than Paradigm HF, was the SHIFT trial. And basically, while in med school, we all learned that tachycardia is over a heart rate of 100, plenty of data to suggest that even a heart rate of over 70 is associated with worse outcomes in heart failure with reduced ejection fraction. And many patients on high doses of beta blocker or are unable to tolerate beta blocker in either case have heart rates in their 80s and 90s. So this trial looked at a sinus node modulator, an IF current modulator called ivabradine in people in sinus rhythm. So this is not a drug for atrial fibrillation. So in sinus rhythm, on maximum beta blocker doses, if your heart rate is still more than 70, were randomized. There was a trend towards improvement in mortality, but unlike Paradigm HF, it did not reach mortality result positive by itself. But the combined endpoint was significantly positive, which was primarily run by 26% reduction in the risk of heart failure hospitalization. So based on these two, in 2017, 2018, the guidelines were updated, and now there was a class 1 recommendation to shift all patients with ACE inhibitor or ARB to valsartan sacubitril, and persistent high heart rate, a class 2 recommendation to ivabradine. We continue to think about expanding the targets beyond a neurohormonal blockade. In the meantime, in the diabetes world, there was an explosion with SGLT2 inhibitors showing reduction in heart failure hospitalization in those people who don't have heart failure. So basically prevention of heart failure. And the bottom line is that from a mechanistic study, these drugs preserve renal function, improve aortic stiffness, aortic function, endothelial function, improve cardiac function, including reduction in left ventricular hypertrophy and diastolic function, and they decrease visceral adiposity and metabolic changes that leads to increased ATP production as well. If you put all of these things together, the question comes up, not only could these drugs help in patients with heart failure, but what does any of this have to do with diabetes, and that perhaps these are cardiovascular risk modifying agents that should be used irrespective of diabetes. On the basis of that, there are 2 trials now that were done. One, DAPA-HF and heart failure with reduced ejection fraction with dapagliflozin. And one can see here, these patients were incredibly well treated at baseline, 90+% on beta blocker, 90+% on RAS modulator, 70+% on MRA. And on top of that, if you add dapagliflozin, there was a substantial 26% reduction in cardiovascular death or heart failure hospitalization. Heart failure hospitalization was reduced, cardiovascular death was reduced, all-cause mortality was reduced, sudden cardiac death was reduced. The curve started separating early and continued to separate. The other trial was EMPEROR reduced with another SGLT2 inhibitor, empagliflozin, in low EF patients. The only difference between this trial and the other one is that this trial targeted higher risks, more sick patient, had 3 endpoints: cardiovascular death, heart failure hospitalization, total heart failure hospitalization, and renal function preservation in heart failure patients. And the bottom line is that all 3 of these endpoints were met substantially, highly statistically significant, and highly clinically relevant. And then there was another trial called SOLOIST. This was only in diabetic patients. Unfortunately, this trial ran out of funding so stopped early, but the bottom line is that showed similar beneficial trends. Okay, so now let's look at the journey of the patient with heart failure. So you have these patients that develop heart failure because of the risk. The risk goes up, and then you develop heart failure. So you're all of a sudden you're a high-risk person. Then you get started on your usual medical therapy, ACE inhibitor, beta blocker, what have you. Your risk comes down, but it is still there. It doesn't go away all the way down to zero. And then on stable medical therapy, your life is going okay. You're kind of class 2, you're on your triple therapy, and then you start breaking through. You start developing more symptoms, you require more diuretic, you come into the emergency room. This is what we are now terming as worsening heart failure. And the importance here is to manage these patients aggressively at this point to bring them back into the residual heart failure risk, because if you don't manage them aggressively at this point, they progress to the other end and become advanced heart failure, and they need transplant and VAD. So in that sense, there was a trial done called Victoria trial with vericiguat. It is a cGMP enhancer. It is a soluble guanylate cyclase stimulator that increases cGMP, as we know that cGMP through PKG signaling has beneficial effect on vascular, endothelial, cardiac, renal, and skeletal muscle function. This was looked at in the Victoria trial. The difference between Victoria trial and all these other trials that I was mentioning before is that this is not a sort of a standard heart failure with reduced ejection fraction trial, but this was a trial on worsening heart failure patients who are breaking through standard of care. So one thing to notice here is that the placebo event rate in the previous trials that I've shown you, 1-year event rate was about 15%. Just look at the placebo event rate in this group, over 35%, 2 to 3%, so really high risk group of patients. There was a 10% reduction in cardiovascular death or heart failure hospitalization, which was statistically significant, but you may think, 10% relative risk reduction is really not that big. I apologize that this is a very data-driven slide, but the bottom line here is that remember that 10% reduction of a very high-risk group of patients still gives you a very high absolute risk reduction, because the relative risk was so high in Victoria as opposed to the other trial. The absolute risk reduction of 4.2% is comparable to the other trials, if not a little bit better. And the basis of this result, just last week, vericiguat was approved by the FDA for worsening heart failure management. I'll skip this slide. We know that patients who have iron deficiency, if you replace that iron, irrespective whether they have anemia or not, iron deficiency, regardless of anemia, improve heart failure patients and how they feel, but we did not have clinical endpoint data. So another trial that was published in Lancet about a month ago was a firm AHF. Heart failure patients who got hospitalized had iron deficiency, regardless whether you have anemia or not. We really, really need to think about iron deficiency as a disease, irrespective of anemia per se, because you can have ATP generation and mitochondrial function degradation with iron deficiency, regardless of anemia. And as you can see, there was a 25% reduction in heart failure hospitalization over 1 year with the use of IV iron replacement. Finally, we continue to go back to some sort of inotrope, and we had all of these inotropes that work by increasing intracytosolic calcium, like dobutamine and milrinone, that increases the risk of sudden cardiac death. We finally found an inotrope, which we are calling a myotrope, omecamtiv mecarbil, that increases the affinity between actin myosin, which is calcium independent, increases contractility. That was tested in the Galactic HF trial. Unfortunately, the trial did not show as gangbuster results. It did meet its p-value, but there was no reduction in mortality at all, and about a 1% absolute reduction in hospitalization. It will be interesting to see what happens with this trial. So this is my last slide, and the bottom line is that at this time, we have shown about 5 pathways: angiotensin 2, norepinephrine, aldosterone, neprilysin, and SGLT2, modulation of which by 4 drugs ARNI, evidence-based beta blockers, MRA, and evidence-based SGLT2 inhibitor are associated with substantial reduction in morbidity, mortality. I think this quad therapy is now the new foundational therapy in HFrEF, and a lot of more things that are being tried. Very, very much appreciate the opportunity to talk to you, and I'm really sorry for the rush because I got to jump off to the cardiology grand rounds. Thank you so much.
Thank you, Javed. No, that was fantastic. And in 10 minutes, you gave us the bird's eye view of the whole adult world and what we can look forward to. So thank you again for that. Bye. So lastly, we'll move on to a poll question, and we'll have time to take some more questions and answers. The panelists will hang around, and you can either put the questions in the Q&A, which is what we'd recommend. For the cardiogenic shock, what is the common missed type of shock in pediatrics? Hypovolemic, distributive, cardiogenic, septic. And Renata can comment on the poll results here.
Yay!
Yeah.
Everybody's gonna think everything's cardiac. No, was just most introduction to my lecture, just to point it out that the most common things is septic, but it's not uncommonly those patients receive a huge amounts of volume when they get into the ER. They're all tachycardic, tachypneic, until the X-ray is done. So they already receive a lot of fluids and they frank pulmonary edema, which is it's a snowball. It's gonna just get towards the respiratory distress, the worst cardiac function, and it is very common, unfortunately, for us to see it when they call us in the ER. We are biased because we're just called when the patients are already decompensating. So that's why I wanted for everybody just to keep this in mind. That is what the clinical signs that you can start suspecting when you see a patient that shows up in shock in the ER, mostly because the earliest that we recognize those signs, we can direct the appropriate treatment and avoid the bad outcomes of cardiogenic shock.
Yeah, absolutely. And specifically when we're talking about infants and neonates, cardiogenic shock should be right up there, because all of them will get diagnosed with septic shock, because that's what neonatologists and ER physicians do. But cardiogenic shock should be right there as a follow-up, even for neonates presenting to the ED. We can have the next question. What is the most common vasoactive drug combination utilized in your practice for patients in acute decompensated heart failure? There is no right or wrong answer for this. We just wanted to get a audience poll essentially for this. And Nida can join in and comment on the response.
Right, so as expected, milrinone and Appian looks like zero response to no milrinone. So, it just makes me wonder that if milrinone wasn't here, let's say there's a shortage or some, issues that come up in the drug world, where we would be. And I think we would probably see use of levosimendan go up, actually, as it's kind of almost second in line, a little bit hand in hand. So it would actually be interesting to see some trials that compare directly milrinone and levosimendan in the end-stage heart failure patients.
Yeah, absolutely. And in the Q&A box, there was also a question about dopamine as an alternative agent. If milrinone was not available for a certain group of patients. And do you want to comment on that?
Yeah, so I think I missed the question, but dopamine in lieu of milrinone, I think I alluded to this a little bit. Dopamine, epinephrine, norepinephrine, dobutamine, they will all still give you that catecholamine response that's not as intensified, I guess, if you will, with the inotropic response that we see with milrinone. You also at the inotropic doses, you're not also going to get that vasodilatory effect with dopamine. So I wouldn't really say dopamine as a replacement necessarily to milrinone. I would say that if you do have to use an inotropic agent and you don't have milrinone, you're probably going to want to think about adding a vasodilator, such as, for example, nitroprusside, or in more rare scenarios, nitroglycerin.
Yeah, and one of the other agent that we didn't talk about as much here, but is quite potent, is isoproterenol.
Yes.
And so if you're looking for an agent that has both agonistic and dilatory properties, then I would consider isoproterenol as an alternative too, especially for patients with right heart dysfunction. It's a very, very potent inotrope for the right heart, and certainly a good chronotrope also if required, without a significant increase in the metabolic oxygen consumption of the heart.
Absolutely. Thank you.
All right, we got the last poll here from Dr. Butler. Which of the following therapies have been definitely shown to reduce cardiovascular mortality in heart failure patients with reduced ejection fraction? Myosin activators, neprilysin inhibitors, intravenous iron, and IF channel blockers. Okay, let's see the polls. I know Dr. Butler had to leave, but neprilysin inhibitors, most of the respondents have chosen. And yes, as both Dr. Jeewa mentioned and Dr. Butler mentioned, the data supporting the use of ARNIs, not neprilysin inhibitors just in isolation, but as a combination with angiotensin receptor blockers, have really changed the way chronic heart failure is being practiced very rapidly. I think in the last year and a half, the prescription for ARNIs have skyrocketed for chronic heart failure just because of how impactful the paradigm trial was, the paradigm study was. And again, remembering that these are patients who are on optimal standard therapies already, including high-dose ACE inhibitors, high-dose enalapril. And even when added to that combination, the ARNIs were able to further reduce cardiovascular mortality. And so I think that's an important mechanistic improvement in heart failure therapies, and something that we have to increasingly use, or think about using at least. Excellent. Sasha, do you want to close?
Yes, thank you very much. I think that today we reach an amazing results. As you see, what we learned with the academy, that we will be able to reach at the same time 400 people all around the world. And I'm sure that for a long time we'll be not able to do the same. So I'm sure that the program that you think and prepare for all the world was amazing, Shri. I received a lot of comments out of the Q&A and chat. And this is something that we really appreciate. You know Gil better and better than me, so I'm sure he's very happy and he's testing every time about this. So you are most welcome for the second part and for a new meeting. So we wait for you, and thanks to all the people all around the world. I'm sure the message was clear and was a fantastic speaker all around the world.
Thank you all.
Thank you very much. Ciao, Sasha. Ciao, Shri. Thank you very much for everything.
Thank you very much.
Thank you, Tony. Thank
Ciao,
you,
Nida.
Aamir.
For having us.
Thank you, Aamir.
Thank you so much.
Thank you, everybody.
It was
Bye.
amazing.
Thank you all. Bye.
We got the 2 bucks, those. What about you? It's okay.
Yeah, we did it. Bye.
Bye.
Life
Bye.
Ciao.